And the next talk in line is TAVR in low risk aortic stenosis and AR, and with none other than Dr. Ashish Mandale, who's one of the most experienced TAVR operator in our country. Dr. Ashish, please.
Good afternoon. And at the outset, sincere thanks to Dr. Jayagopal for this wonderful opportunity. All of us would agree that TAVR has revolutionized the treatment of aortic stenosis. Initially limited to patients at high surgical risk, the indications have been expanded ever since to include both intermediate and low risk patients. And by low risk, what we mean are patients less than 65 years of age, those with an STS score of less than 4, and healthy patients above 65 but without comorbidities. And the evidence is such that the guidelines even consider TAVR as one of the preferred options in low-risk subsets after incorporating patient preferences, the so-called shared decision-making model. And this shift in the approach to treatment of aortic stenosis, especially low-risk aortic stenosis, is based on data from 3 major randomized controlled trials: NOTION, PARTNER 3, and the EVOLUTE low risk, and at least an equal number of smaller non-randomized studies. Now, the PARTNER 3 trial compared balloon expandable SAPIEN valve with SAVR in low-risk patients with aortic stenosis, and the 3 main findings of the PARTNER trial published in the New England Journal of Medicine: TAVR was superior to SAVR with regards to the primary endpoint of death, stroke, or rehospitalization at 1 year, and this was evident even at 30 days. TAVR was associated with a lower risk of new onset AF, shorter index hospitalization, and faster recovery times. Almost simultaneously, the EVOLUTE low risk trial also looked at comparing EVOLUTE versus SAVR in low-risk patients, again published in the New England Journal of Medicine. The 3-year outcomes of the EVOLUTE low-risk trial was recently published in the JACC. And the findings were that the all-cause mortality or disabling stroke was significantly lower in patients treated by the self-expanding EVOLUTE valve. And what is striking is the differences in the Kaplan-Meier rates for TAVR remained broadly consistent over the 3-year period. Now, both these studies show that TAVR is superior to SAVR in terms of procedural outcomes. But then what about the durability? And I'm sure purists would be skeptical before adopting this technology. This is the published 8-year outcomes from the NOTION trial, published in 2021 in the European Heart Journal, which compared the first generation transcatheter heart valve with TAVR, and there was no difference in all-cause mortality, stroke, or myocardial infarction. And what was most striking was structural valve deterioration was more evident in the SAVR group. So the key observation from the randomized as well as the small non-randomized studies were that TAVR was associated with lesser mortality, less stroke, and less new onset AF, but consistently across trials, there was an increased need for permanent pacemaker and increased paravalvular leaks with TAVR as compared to SAVR. Now, when we were dealing with high-risk and intermediate-risk patients, we were focusing more on procedural success. But when we apply this to low-risk patients, we need to move away from just our mere procedural success, not just mortality and stroke, and not just the quality of life, but because we are dealing with younger patients who are active and a large proportion of bicuspid valves which were grossly underrepresented in the randomized trials. We need to talk about the hemodynamics, its implications on the durability, patient processes mismatch, the need for coronary reinterventions, and possibly, because the patient outlives the transcatheter valve, future TAVI in TAVI. So essentially, the durability valve is important, and we have enough data now to show that PVL, especially moderate to severe PVL, has an adverse impact on the durability of the valve, patient processes mismatch, and the hyperattenuated leaflet thickening, which is being recognized of late. Of course, stroke in low-risk AS should be avoided. Future coronary access, as I mentioned, feasibility of TAVR in TAVR, and surgical explantation of the valve if required. PVL, especially moderate to severe PVL, is more common with TAVR, more so with self-expanding valves as compared to balloon expandable valves. And the factors responsible could be anatomical or procedural. And this is a comparative assessment of PVL post-TAVR with all the commercially available valves. And as you can see, some of these valves have brought down the incidence of significant, which is moderate to severe PVL, to less than 3%, as you can see on the left side of the graph. And what is most striking is that almost all the currently available TAVR valves have undergone an evolution. They have an outer skirt which significantly reduces or may even prevent moderate to severe PVL. Now, it is believed that roughly about 1/6 of patients have a small annulus, arbitrarily defined as less than 21 millimeters. Patient processes mismatch, unfortunately, is more common with TAVR, simply because the internal dimension of this surgically implanted valve is at least 2 millimeters smaller than the TAVR valve, and also because the TAVR is guided by CT assessment of, or CT measurement of the annulus, which is gently larger than what the surgeon gets to see on the table. But despite this, a PPM is recognized in about 4 to 20% of patients undergoing TAVR. So in younger patients, small annulus and low bleeding risk, it would not be a bad option to consider mechanical prosthesis because it takes away the need for a repeat procedure, thereby worsening PPM. Now, a lot of attention has been focused on the HALT, or the hyperattenuated leaflet thickening, which is made out on a CT. And its importance is in that it's a harbinger to prosthetic valve dysfunction. And what you get to see is hyperattenuation on the contrast CT. Earlier on, or early on in the course, it's a subclinical valve dysfunction. You just have increased echo gradients, but later on, these patients develop severe valve insufficiency and heart failure. The factors responsible for HALT could be patient processes mismatch, number one, the non-use of oral anticoagulants, especially in smaller valves, because smaller valves have a propensity for microthrombi formation, and severe commissural misalignment. And we have data to show that such severe commissural misalignment independently predicts leaflet thrombosis. As we mentioned earlier, stroke is a complication which is unacceptable, especially in low-risk patients. And we have many ways to tackle this these days. Why does stroke occur? Because of densely calcified valve, very narrow orifice, aggressive predilatation, which is often required in bicuspid valves because of the anatomy. So you have delivery systems which have a distal flexion, avoiding the greater curvature so that atheroma from the greater curvature does not embolize. And even though protected TAVR is not supported by scientific data as of now, it could have a place in the management of low-risk patients because the cognitive function was not seriously addressed in those trials. What about future coronary access? In low-risk patients, that is, I'm talking about less than 65, the prevalence of CVD could be as high as 20%. Possible progression of disease has to be factored in. And the ability to access the coronaries post-TAVR depends on the relationship between the valve, that is the stent frame, and the aortic root, the position of the valve leaflets, and also the commisural alignment in relation to the ostia. And what I mean is, if the valve commissures, the transcatheter heart valve commissures, are against the coronary ostia, it is extremely difficult, if not impossible, to access the coronaries. Also, the design of the valve. The height of the stent frame, the valve extends above the coronary ostia, it becomes difficult. The cell size is smaller, it becomes difficult. And the design per se, supraannular valves in general, are associated with a more difficult coronary access as compared to balloon expandable valves. I talked about commissural alignment, and it is extremely important in determining the longevity or the durability of the valve, because a properly aligned valve aligned to the commissures decreases the stress and strain of the leaflets, increases valve durability, it facilitates better coronary access, less of PVL when they are aligned properly, exactly like what the surgeon does on the table. And should a TAVR and TAVR be required, because your first valve is away from the coronary ostia, a modification like the Basilica technique could be possible. Now, to achieve commissural alignment, almost all manufacturers have specific deployment techniques, essentially a specific position of the delivery system before insertion. Now, the crimped view utilizing a cuspal overlay the right and the left cusps, and then after deployment, there is a fully expanded view as well. Now, this is a novel technique, the octa-align technique, which simply extrapolates a clock angle to the anatomy of the cusps. And what you have is an obtuse right angle or an acute angle, depending on the spatial orientation of these cusps. And if the coronary artery takes off from the center of the cusp, you could have an extreme right angle, which is called arbitrarily called as a 3 o'clock position. And the proof of the fact that this works is this: a post-procedure CT, a 0-degree misalignment, which means the valves are completely aligned to the commissures, the transcatheter valve completely aligned to the commissures, a 0-degree misalignment. In a tricuspid valve, this is from John Joes at Velo. But at least 40% of our patients have bicuspid valve. Indian population seem to have 40% of those have bicuspid valves. Herein, a commissural alignment is not possible, so you use a coronary alignment, wherein we mean that the valve commissures are away from the coronary ostia. And this is again, the proof that the post-procedure CT, the coronary is extremely away from the commissures. And this is, from our own series. Here again, there was absolute 0-degree misalignment. What about coronary access? Low-risk patients, they could outlive the life of the valve. Coronary ostia above the neoskirt, not an issue. You could use either a balloon expandable or a self-expanding. Ostia below the neoskirt. Now, if the first implanted valve was a self-expanding valve, makes sense to go for a balloon expandable valve. But if the coronary ostial height is low, which means that they are below the neoskirt with a narrow sinotubular junction, your life is miserable. You probably go for a surgical explantation of the valve, which is extremely difficult, I'm told. But maybe with increasing experience of surgeons, it could be possible. Now, what about TAVI native AR? Now, the disadvantages of treating AR, non-calcified leaflets, leads to inadequate anchoring, dilated annuli, and high stroke volume, which interferes with precise positioning of the valve. So what is recommended is a substantial oversizing of the transcatheter heart valve to the extent of 20% or more with the balloon expandable and 40% or more with the self-expanding valve. There are two such valves available, dedicated valves, the J valve and the Gina valve. Both are self-expanding platforms, porcine leaflets, and the type of deployment of the Gina valve makes it a very attractive option because there is less of calcium. Shall I just take 30 seconds more? It essentially clips the device to the native leaflets, and this engagement allows proper anchoring independent of cusp calcification, making it ideal for severe AR. But does this mean that at this point in time, we don't have options because these valves are still undergoing phase 3 trials? Now, you could use either a standard self-expanding or balloon expandable valve. It has been used in our country in 2016. A few eyebrows raised because a 45-year-old male post when or treated infected endocarditis. I don't know why he did not go for surgery. The CT of this patient shows absolute lack of calcification of either the leaflets or the annulus. And this was treated by a balloon expandable valve, again courtesy John from Willow. Oversizing, similar positioning, very slow deployment, and nothing is different. And this is what you end up with. So, in summary, transcatheter heart valve for low-risk AS is a reality, but with certain caveats. You need to factor in so many variables. Patient preferences, of course, but the patient's anatomy, including the anatomy of the sinotubular junction, the position of the coronary ostia, and proper deployment techniques which increase the durability of the valve. And the so-called shared decision process is a way to go. Transcatheter heart valve for pure AR is possible, but I think more data is required before it can be incorporated into clinical practice. Thank you.
Excellent talk as usual, Ashish sir. And it's now in Western world, it is the spectrum is shifting rapidly towards the younger population, and this point of shared information and that discussion part is very crucial. In one of the recent data, it was seen that in US, from in the age group of 60 to 65, nearly 45% of patients opted TAVR. Now, it is now important to discuss the lifetime management of aortic stenosis in these patients. So, we have to discuss about TAVR maybe 10 years later, or maybe TAVR another 10 years later. So, it's extremely important. But the curious part is, what will be a heart team meeting at the age of 60? How would what will be the surgeon's comments in a heart team meeting between 60 and 65 as of now? Any thought on that?
I think the surgeon is likely to say we'll put in a bioprosthetic valve, and subsequently, maybe 8 to 10 years later, can go for a TAVR, a valve in valve.
Thank you. Thank you, dear Ashish, for that excellent talk. Of course, the most experienced TAVR operator in India. And I was astonished how a life-threatening complication was tackled during a TAVR 3 weeks back. Hope you remember it. I was an extremely skilled operator. One question I would like to ask you is that in the third trial, that I think it is Evolute Pro 3, it was seen that the complete heart block is higher in TAVR compared to SAVR. And along with that, bicuspid aortic valve is much more common in our country. So taking into these 2 points, would you consider that TAVR should not be an option in low-risk patients, especially when he is a young patient?
But now we have actually the implantation technique of both the self-expanding and the balloon expandable valves have evolved over a period of time. So these days, the pacemaker requirement rates have come down significantly, because earlier it used to be the depth of implant was much more as compared to what we're doing now. That is one. The bicuspid anatomy, unfortunately, I think about less than 5% in most of these randomized trials, but in Indian populations between 35 and 40%. So we have used all valves, both balloon expandable and self-expanding, with similar results. And there's certain papers which suggest that they do not behave differently from tricuspid anatomy, except that your sizing and positioning are different. The sizing of the valve is different, and the positioning of the valve as compared to a tricuspid anatomy is different. That's all.
Thank you, Ashish. This was a very wonderful talk. And with that, we come to the end of this session. Thank you all.
Thank you all. We move on to the next session. May I please invite the chairpersons for the next session, Dr. George Tayal, Dr. Joseph Kardos, Dr. Prakash, and Dr. Thomas Matthew, please.
Good afternoon, dear friends. Without losing much time, I think we have to start. from the heights of TAPVC and coming down to the scenario of electrophysiology. How to calm the VT storm. VT storm per se is a medical emergency which is characterized by repetitive episodes of sustained VT in a limited period of time. Its occurrence represents in the natural history of a patient with a structural heart disease associated with a poor short and long-term survival, especially in patients with a reduced ejection fraction. In general, a multidisciplinary approach is mandatory, including the medical, that is the antiarrhythmic as well as interventional approach. To highlight this difficult topic, we have an eminent electrophysiologist, Dr. Narayanan Nambudiri, and I request him to highlight the topic. Over to you, sir.
Thank you, sir. Good afternoon, everybody. Respected chairpersons and dear friends. The clinical spectrum of potentially fatal condition, that ventricular tachycardia storm, can be defined as 3 or more sustained and separate episodes of ventricular tachycardia, ventricular fibrillation, or appropriate ICD shocks in a patient who already had an ICD within a span of 24 hours. The sustained VT is also defined as that lasts at least 30 seconds, involves hemodynamic compromise, or requires intervention to terminate the episode. This clinical spectrum of electrical instability, extreme electrical instability, the presentations can vary from recurrent ICD shocks to multiple episodes of potentially fatal arrhythmia episodes or even cardiac arrest. In the next 7 or 8 minutes, I'll go through the approach to a patient with VT storm. The step 1 is ventricular tachycardia confirmed, that the diagnosis, it should be made sure that the condition that we deal with is a ventricular tachycardia and not an SVT or some other condition. Are the shocks appropriate? That also should be confirmed. Then the step 2 is to define the substrate and the precipitating factors. The step 3 that also I would focus on is the treatment strategy that involves correcting the precipitating factors, arrhythmia therapy to control the electrical storm, and finally the precautions to prevent recurrences. So first, we know the differential diagnosis of white complex tachycardia. I'm not going through, but there are certain clinical mimics that we all know. That is, when a patient with acute MI presents with sinus tachycardia and Bundy branch block like RBUB or LBUB, many times we know patients get shocked with a presumptive diagnosis of VT without any termination of the tachycardia. Then only one would think of sinus tachycardia with aberrancy. Pre-excited tachycardia is another rare mimic. SVT with aberrancy, of course, an important one. And in a patient who already have an ICD, SVT with aberrancy or even electrical noise, a non-arrhythmic condition can itself lead on to a false diagnosis of VT storm. One should look for ongoing ischemia, an important condition that predisposes to VT storm, apart from dyselectrolytemia, structural heart disease, and withholding drugs, amiodarone or beta blockers. A patient who has been controlled well for so many years now stops amiodarone or beta blockers, comes with a VT storm, worsening of the heart failure, myocarditis, and another potentially missed that can be missed is patient on chronic amiodarone therapy. When they develop hyperthyroidism, they can have electrical storm as a presentation. One has to define the substrate, look at the baseline ECG, evidence of channelopathies, epsilon wave, intermittent VPC, conduction blocks, evidence of cardiomyopathy. Like this patient who had an electrical storm in the past, the after cardioversion was noted to have Brugada pattern. So this could be missed easily if the patient comes with polymorphic VT without knowing the underlying, having the underlying ECG, previous ECG, or knowing the underlying condition, we would end up treating with a multiple unnecessary modality. Very important thing, we should differentiate between two entirely different spectrum of VT storm or ventricular arrhythmia, that is monomorphic VT versus polymorphic VT. They are entirely different clinical entities, or one can say. The patients with the monomorphic VT generally have a scar-related underlying substrate, either ischemic or non-ischemic cardiomyopathy, or VT in structurally normal heart can also occur. While in polymorphic VT, it's a result of acute ischemia, dyselectrolytemia, toxic or infective myocarditis, or genetic arrhythmia syndrome. Like this patient who has got a Torsades polymorphic VT, while you cardiovert or you see the onset of this, you can see the long QT at baseline, a bifid T wave, R1T initiating the tachycardia. This patient had presentation postpartum, bifid T waves, and this patient had a long QT syndrome 2 HCRG mutation, KCNH2 mutation with HCRG protein involvement. When we looked at our data 10 years back, the commonest type of presentation was patients with severe LV dysfunction, patients with a monomorphic VT, and with a structural heart disease. Triggers were mainly acute ischemia or hypokalemia. The management involves correction of electrolyte abnormality, ischemia, decompensated heart failure should be treated, beta-adrenergic blockers, amiodarone, lidocaine or mexiletine, then neuraxial modulation, mechanical ventilation, anesthesia, and even catheter ablation for VTs or triggering focus of VF. It is more of a, should be tailored to the substrate. Patients with channelopathy like Brugada should be treated with isopranolol, quinidine, or even catheter ablation, while those with the long QT should be treated with beta blockers, pacing, magnesium and potassium, antiarrhythmic therapy, and autonomic modulation. And this consensus statement, which I was also fortunate to be a part of, also suggested that in patients with IHD and VT storm refractory to antiarrhythmic therapy, catheter ablation can be considered. Indication for radiofrequency ablation is varied. Predominantly, it is polymorphic VT initiated by Purkinje5 or VPC. The drugs, additional drugs have limited role except probably lignocaine and mexiletine. Adrenergic blockade is a very important component, like this percutaneous stellate ganglion block. Before and after, one should see the difference to understand the impact. Then the procedure for the stellate ganglion block, one can go in detail. Primarily, this is the way it is to be approached. Carotid artery here, this is the longest coli. After injection, one can see the expansion of the space there. This is lateral to thyroid. One should focus on the C6 level, which is known as the Sagney's tubercle, which can be easily palpated. And the available stellate ganglion, we approach at the C6, though it is at C8, T1, by pushing laterally the sternocleidomastoid and the carotid sheath, and it can be approached easily and ablated. This cardiosympathetic thoracotomy can be done by supraclavicular approach also. This EHRA consensus is coming with next month. It is renamed it as a clustered ventricular arrhythmia. This is my last slide. VT storm, the common errors in clinical practice is aggressive sympathetic blockade in stable monomorphic VT, making the patient unstable. Rapid amiodarone bolus or IV beta blockers in patients with monomorphic VT with a borderline BP and ventricular dysfunction, again making them unstable. Not ruling out ischemia in the initial phase itself, and not considering stellate ganglion block in indicated cases. Bilateral stellate ganglion block as the initial option, which can lead on to hypotension, and not reprogramming ICD in the patients who already had a device. So concluding, ladies and gentlemen, identification and correction of precipitating factors in therapy with amiodarone and beta blockers form the cornerstone of antiarrhythmic therapy. Neuraxial modulation and RF ablation can be useful in refractory cases. A substrate-specific approach provides an excellent outcome in these cases. Thank you.
Yeah, very good, Dr. Nambudiri. Now, two things. Are we in the normal clinical scenario, overusing the amiodarone therapy, I think we have the amiodarone. Are we in the clinical scenario, in the hospital setting,
Yeah.
are the clinicians overusing in terms of dosage or how long do they treat the amiodarone?
So the question
In
is
the
that whether we
setting
are
of
overusing amiodarone?
Overusing. Number two, what about the role of phenylephrine? Phenylephrine, which has been advocated in the treatment of VT Strom, phenylephrine, which does not have an effect on the adrenergic beta receptors. Have you, this molecule, is it familiar to you? Phenylephrine, which is used very much in the Western scenario
So phenylephrine, we don't have any personal experience.
to settle the VT Strom.
Yes, sir. Phenylephrine, we don't have a personal experience, but amiodarone, it's indicated as a class 1 agent in all these patients, probably except those with an underlying long QT syndrome or those with a prolonged QT to begin with. Other conditions, and maybe Brugada, channelopathies, it is not indicated. Otherwise, amiodarone is considered as a class 1 agent, but after an initial infusion, if it is not controlled, we need to go for an add-on therapy.
Okay, once amiodarone is started, how long should you initiate the therapy or continue the treatment? Is there a time limit?
The overall loading dose of amiodarone followed by this thing in a stable patient, you know the amiodarone loading dose should be activity, the entire effect will come with almost 20 grams. But in an electrical storm, we are not, our purpose is not that. So it is acute control of the arrhythmia. So we have to go for, once the hemodynamic instability sets in, that is major problem with IV amiodarone because it contains polysorbitol and it can cause peripheral vasodilatation. In that case, we have to reduce the dosage or go for an additional therapy. A good add-on is always mexiletine or a lignocaine, provided beta blocker had already been started in these patients.
Because there are a lot of specific side effects associated with the use of amiodarone, especially the thyroid problems. That is why,
Yes, sir.
and lot of clinicians, I think they're using amiodarone for a longer time also.
Yeah, major problem, the risk associated with amiodarone in acute setting. It's a life-threatening situation and any other contraindication or any other long-term complications would be irrelevant in this setting. So in this case, IV bolus, intravenous bolus and rapid amiodarone infusion can produce hypotension and make them unstable. Especially with the monomorphic VT, if that happens, patient can be taken for an overdrive pacing termination or cardioversion.
Thank you. Any questions from the audience?
Just to make a comment, I think any ambiguous wide complex tachycardia should be assumed to be VT, especially in a patient with structural heart disease. Thank you, Professor Narayan Namatri, sir. May I call upon Dr. Prabha Nini Gupta, madam, to please come and elaborate on a topic, what's new in CPR and how to optimize. Welcome, madam.
Thank you. I'm right from the start taking an anticipatory bail that I might have to stop in the middle because I have a lot of slides. This is my favorite topic. As you know, when you see a person unresponsive, the first thing is you activate the emergency system and start CPR. You have to push hard and push fast at the rate of 30:2. And the first operator who comes for the CPR should start CPR within 2 minutes, do a head tilt chin lift, give a rescue breath and continue the CPR. And defibrillation should be done only after 5 cycles of CPR. This preserves the brain. Now coming to my actual topic. The updated CPR guidelines came in 2020, then a new guideline came in 2022, and then January 2023. However, I'm talking about the 2013 guidelines because they are my favorite guidelines. Now, in 2020, AHA recommended that in a COVID patient, the operators should wear a PPE kit, N95 mask, and then go for CPR. Now, ACC and AHA recommend only high quality CPR. Now, what is high quality CPR? The chest compression fraction should be more than 80%. The compression rate should be 100 to 120. The compression depth in an adult should be 50 millimeters, that is 2 inches in adults, and 1/3 of the AP dimension in infants and children, and avoid excessive ventilation. When bystanders start CPR, high quality CPR, the patient is 4 times likely to recover with a favorable neurological system. Now, so what are the 5 components of high quality CPR? That was what was defined in the 2020 guidelines. So I've already said it, I'm telling it again. Compression depth of 100 to 120, compressing up to 5 centimeters, and the most important thing is avoid leaning. Many people lean on the chest, and this reduces the recoil, and that reduces the effectiveness of CPR. The other thing is to avoid over ventilation. So if you're giving ordinary breaths, you make it 2 breaths for every 30 compressions. And if you're using an advanced airway, it should be only 10 breaths per minute. Now, how can we improve CPR outcomes? It has been found that training a team leader improves the CPR outcomes. And that is what you call high quality CPR. Now, I'm actually quoting Nick Nigam from USA. It has been found that training a team leader improves the outcome of CPR. So ideally, if you have plenty of operators in the hospital, a ACLS team should have 6 people in it. The first person within 2 minutes starts the compression. The second person comes with a defibrillator, starts an IV line. The third person is responsible for the airway, whatever it is. The fourth person keeps medications ready in syringes and gives it to the second person. The fourth person actually documents what's happening. Because, right now there's a concept that from the time of onset to CPR, you should calculate how much of percentage of compression is going on. The other reason this is important is in many centers, after 15 minutes of high quality CPR, or in some centers 20 minutes, they recommend going for ECMO. So this is very important, and documentation, and the 6th position is the team leader. So this I've already told you, and this is the guideline, which is my favorite guideline. This is 2013, but I'm quoting this now. The survival from out of hospital cardiac arrest is between 3 to 16%, even with high quality CPR, and CPR survival is better from 7 a.m. to 11 p.m. In the operating room, survival is 37%. So, how can we improve our CPR? So, first is we should generate adequate coronary perfusion pressure. What is coronary perfusion pressure? That is the difference between the aortic diastolic pressure and the RA pressure. The minimum allowed is 25%. So, if you can measure your compression, you can improve it. And here is a picture of a CVP where the operators are looking at the RA pressure, and this is a modern monitor where you can see the aortic diastolic pressure. So the coronary perfusion pressure you can calculate during your CPR. But now there are even better techniques. I'm coming to that in a minute. And they say even looking at the SpO2 is useful. Now, you have to minimize interruptions. And this I've already told you. Full recoil is very important. So the next thing is you can measure the end tidal carbon dioxide, and this should be more than 20 millimeters of mercury. Now, end tidal carbon dioxide, if it suddenly rises, it denotes return of spontaneous circulation. But it has many other uses. In olden days, people used to look at the fogging of the endotracheal tube to see if the tube is in position. But with the end tidal carbon dioxide, with the sort of flat line, you can make out the tube is out. Same way, in this picture, with the end tidal carbon dioxide graph, you can see return to spontaneous circulation. An end tidal carbon dioxide of 10 is ideal during CPR. If it's less than 10, you have to improve your compression. Then the waveform is also equally important. It gives lots of things. I'm not going into that. But this particular waveform shows it's a supraglottic placement of the tube. So it has been found that keeping the tube leader at the foot of the bed makes better CPR. You should minimize the pauses. Now, if the person does not recover after 3 DC shocks within 20 minutes and the person can afford it, an ECMO has been recommended. And I know that I'm almost out of time. Is it the 7-minute time or 8-minute time? The patients who benefit from ECMO are refractory cardiac arrest with reversible causes, those who had high quality CPR, younger age, ETCO2 of 10, signs of life under CPR. Then 2 terms, no flow time less than 3 minutes and low flow time of less than 60 minutes. So those are the patients who do well with the ECMO. And I'm quoting the ARREST trial which came in Lancet. Here it had somewhat unbelievable results of 1 out of 15 of mechanical CPR patients survived, whereas 6 out of 14 patients, that's 43%, survived with ECMO. But later studies showed that survival with ECMO for out-of-hospital cardiac arrest is only to the tune of 6%. They believe that this was a very rare study, but it has come in Lancet, and that is why I'm recommending it. So it should be started at 16 minutes. Now, actually, I haven't even touched on my topic, but I have to tell 3 more points and then I'll finish. Lucas device has been studied in different trials, but paramedic trial, but good high quality CPR has better outcomes. The Thumper device has been tried. It reduces rib fractures and has a better survival rate, but has not become very popular. The Zoll Autopulse failed, so it is inadequate. Now, just 3 or 4 more points and then I'm done, because I have not touched on the 2022 guidelines. So the 2022 guidelines have looked at all material and they advise against cooling the patient. In the newborn, they have studied that if the newborn is less than 34 weeks, delaying tying the cord helps the baby. Keeping the baby at 23 degrees centigrade instead of 20 degrees reduces mortality. Keeping the baby next to the mother and wrapping in a plastic wrap improves the survival of the baby. And there are many more points about like when to do CAG, etc. No, I'm finished. All these points, all of you can read because they're all negative points. I told only the positive points. Thank you.
Yeah, thank you, ma'am. An excellent talk. Now, studies nowadays show that the compression only CPR, not mouth to mouth. I think the BLS setup, nobody is doing now, and that is not bringing anything. The compression only CPR
No,
in the
I didn't
BLS
follow.
setup
Huh.
is only required. That is the latest school of thought, I think. So, what is
No,
your
no.
opinion?
What did you say? I didn't follow.
In the BLS
Yeah,
scenario, when you do outside,
yeah.
the compression only.
Yeah, that is
CPR.
compression only CPR. Yeah, it's well known that the most important thing is the compressions, because when the person first has a cardiac arrest, there is adequate oxygenation to the tissue. But still, you have to give some rescue breaths. If you like, I can tell you the story of one patient I had when I was in Alleppey. What happened is, when I was in Alleppey, the ward was as big as this. And when I reached a patient of mine who had mitral valve prolapse with atrial fibrillation, had a cardiac arrest. He was very sick. So I started cardiac massage. Nobody was near me, but fortunately one ICU sister of mine came there. So I started the massage. She came and gave IV adrenaline and atropine, and we massaged the patient, put the patient on a trolley. Then almost 1 furlong away, we took the patient to the ICU. And you won't believe it, the patient started spontaneously breathing, and when we put the monitor, we found that he's having torsade. So we gave him magnesium, and he recovered and went home. So that is high quality CPR. Actually, I was about to tell the bystander that he's no more. Then he started gasping. So the quality of the CPR is very important. And thereafter, I had some 4 or 5 more patients who recovered just with CPR. Okay.
And how long do you advocate CPR?
Yeah, they say that CPR should be given for 20 minutes.
20 minutes,
And
30 minutes?
just before the 20 minutes, you can consider ECMO or the Lucas device. They found that putting the Lucas device does not increase the pause. So all those things have been studied in the guideline. Does Lucas device increase the pause? No. Does transporting worsen the quality of CPR? Yes. Lots of small factors have been studied in the new guideline, which is impossible for me to summarize.
It has,
So what I'm saying is, at 15 minutes, they expect the person doing CPR to get tired, and that's the time to either use a Lucas device or that thumper device, if it's available, or put the patient for ECMO. And they say that ECMO should be introduced either in the field or in the catheterization lab. They believe that interventional cardiologists are very good in punctures, and they should put the ECMO.
but it has been reported
Madam, sorry to
in the
interrupt.
young mountaineers
Sorry to interrupt,
that
sir.
even CPR up to 6 hours have been given and the patient survived. I think short of time we are,
Okay.
Dr. Jayagopal, we are closing the session.
Okay.
And thank you so much. Both of the speakers have done a wonderful job, Dr. Narayanan Nambudiri and Madam. We thank you. Thank you so much.
Thank you. Sorry, madam, we are already behind schedule, and let me now invite the chairpersons of the next very important lecture on my most satisfying interventional case. Dr. Kiran Jacob, Dr. Balakrishna KP is not here. Dr. Suresh, Dr. Trudeep Sagar. Please come. May I also ask Dr. Harikrishnan to join the dais. And may I now invite Dr. Bijulal to make his presentation. Thank you.
Good afternoon. I think we'll directly go on to the case. Bijulal, please.
Thanks to the organizing committee for giving me this opportunity to speak to this audience. Dr. Jayagopal wanted me to discuss about my most satisfying interventional case. So I was thinking about which case to discuss, what is meant by most satisfying case. But I found that there is no one single satisfying case. We get to do a lot of cases, and we have seen a lot of lives, we have saved a lot of lives, some lives we are lost. So there are so many cases. So it is difficult to select among them. So I thought about what makes you satisfied. Is it money? Of course, money makes people satisfied. But I'm in an academic setup, so that doesn't matter much. Challenging cases. So challenging cases, taking challenges. So that with that comes peer recognition, glory. So those makes us satisfied. And compassion. Compassion is something very important. But it is in your early stages. As you grow up, I believe that compassion is a little down in the list. But then comes the call of karma. So probably we are bound to do this, and we are doing this, and so it's a mixed bag. But I think as a matured cardiologist, I think the call of karma makes things happening and it makes me do things. And I'll show one interesting, challenging case, which interesting and satisfying because it's a multidisciplinary approach case. So this is an 80 years old man. He underwent a pacemaker implantation in 2016 for atrial tachycardia, and at that time he was not to have prolonged SUV interval and intermittent LBB. So pacemaker was put in for support, just to, as he required antiarrhythmic therapy. He was noted to have moderate aortic stenosis then, and he had a gradient of 40 millimeter mercury, and his LV dimension was actually normal with an EF of 70%, and coronary angiography showed only minor CAD. So he was just given a VVI pacemaker. Probably VVI was put for financial reasons, I believe. Then he had heart failure symptoms since June 2020. He has history of angina. Clinical examination shows cardiomegaly and an ejection systolic murmur suggestive of severe aortic stenosis. He has clinical heart failure with a pedal edema with a markedly elevated pro-BNP. So this was his X-ray in 2016 after pacemaker implantation. Currently his X-ray is showed a much larger cardiomegaly of around 70%. So this is his ECG now, which shows AV dissociation and the broad QRS, notched QRS, which are of suggestive of RV pacing. This echo currently showed an ejection fraction of 38%. His LV has dilated compared to what it was in 2018. He got a valve abnormality of LAD territory, but with the preserved valve thickness, he got bicuspid aortic valve with the aortic valve with the severe aortic stenosis and mild aortic. The new thing which has happened is because of the annular dilatation, he got severe functional MR at this time. So he got a mixed etiology for LV dysfunction. He got CAD, he got aortic stenosis, he got RV pacing induced LV dysfunction, he got MR which is secondary to LV dysfunction. So he needs something needs to be done. How to proceed? Of course, he needs a coronary angiogram. Of course, he needs a workup for TAVI because the TAVI is going to be less risky in this very elderly man with a high STS score. And of course, you need to do a resynchronization therapy, but it comes only after the primary underlying obstructive lesions are tackled. There's some role for CMR, but we didn't do it because he got obvious etiological factors which are reversible. So we did a CT angiogram which showed a large annulus with a perimeter of 98 millimeter, which is slightly higher than for available TAVR systems. Of course, the 30 millimeter MyWell can be used at that time. But we decided to go with, we are more of a self-expanding center, and for the self-expanding center, this perimeter of 98 was a little higher. Coronary angiogram showed a single vessel disease of LAD, which was calcified. So his options were high-risk surgery followed by CRT or PCA plus TAVR followed by CRT. Challenges with the TAVR being the large anatomy. Challenge with the PCA is patient with the aortic stenosis and LV dysfunction, or need for hemodynamic support during procedure. Maybe a combined procedure is another option. So, but we decided to do a staged procedure because that was more feasible for many reasons. We did a rotablation and put a couple of stents, and actually we had a very good result for coronaries. And after 2 weeks, we took him up for TAVR. TAVR was done with a 34 millimeter evolute R valve. We expected some amount of paravalvular regurgitation because it is a large anatomy. This 34 millimeter valve can be put up to a perimeter of 94, but here the perimeter was 98. So we expected some amount of AR. As expected, it was there. More than mild AR was there, for which, as we routinely do, we do a post-dilation. This is the 28 millimeter balloon, which was the highest size which you can use for a 34 millimeter valve. Even then, he had a mild aortic regurgitation still persisting. But he clinically improved, somewhat improved, because his echo after TAVR, you can see that his MR has improved. There is a mild PVL, there is no aortic stenosis. And if you look at it, you can find that his LV is still dysfunctional. It's not normal LV, it is still dysfunctional. So of course, we had to do something for his, improve his synchrony. So he underwent a LOAD CRT, that is a left bundle optimized CRT. Look at his narrow QRS now with 1:1 AV conduction, and this is his LV function right now. Not right now, immediately after the LOAD CRT. So he has a follow-up of more than 1.5 years. He's doing well. His MR has regressed. It is still there. It is more than mild MR. Moderate MR is still there, but he has regressed from what it was. It was severe MR to begin with. with revascularization, tackling hydrogenesis, and raising organization and improvement in LV dysfunction. His MR has regressed to moderate intensity. Even now he got a mild clinical heart failure. Intermittently he comes with edema, but there are no obstructive lesions or any be tackled right now, except for this moderate MR, which obviously might need a mitral clip infusion. So this case is among satisfactory cases because of the multidisciplinary approach involving coronary interventionist, structural cardiologist, electrophysiologist, and heart failure specialist. And the procedure challenges with the high-risk PCA with rotablation in the presence of severe hydrogenesis, LV dysfunction. And the very good outcome, normalization of LV function as shown by the latest echo and the symptom relief and the patient satisfaction. Thank you very much.
Thank you, Vijayal, for a nice case. I think you suggest, as I said, it is you got the best possible result in this patient with all the possible lesions in him. So any comments from?
Great case, sir. Just one doubt. Is there any specific reason for opting for a self-expanding
At that time,
valve?
2021, we are using mostly self-expanding valve. Our experience was with the self-expanding valve.
Thank you.
Sir, during the procedure or just before that, any use of mechanical support devices?
It was an option, but due to logistical reasons, we had an anesthesia backup, and but patient tolerated the PCA procedure. We were a little bit afraid of. At that time, we were expecting complications, but it went well. Rotablation, rotablation, it went well. We had a backup for an emergency PAV if required. Emergency balloon valvuloplasty if required could have been done at that time, but it was not required. So we did a TAVI 1 to 2 weeks after the PCA.
Any other comments from the?
A great case, Vijayal. In case you need a future coronary intervention, so it looks very extremely good. I'm just asking you, does the choice of the valves make a difference?
So this patient is 80 years old. At that time itself, 2021 itself, I think we are using it. We are implanting it under cusp overlay view also. Both views will be done. Generally, in cusp overlay view, this LCA will be commercial and will be obtained with a self-expanding valve. At that time, we are not practicing for that, but the same technique was being used. At the 3 o'clock position, we will push, and cusp overlay technique will make it sure that it's on the outer curvature. So probably it is aligned.
Thank you, Vijayal, for that excellent case. Now we'll move on to the next case by Dr. Shafiq.
Thank you, respected chairs. Sincere thanks to the organizing committee for giving me the opportunity. So when I also went through the same thought process when Jayagopal sir called me, and but I choose this case for a different reason. This patient actually is a 66 years old male who had a large ASD and was operated in 1990. So he was known to me through one of my family member, and ever since my MBBS days, he was taking my advice for all the consultation and follow-ups. And once I became a cardiologist, he made me his cardiologist, and I was just doing echo. And he had started having exertional angina for 3 years. He was in Middle East. He came back and came to me for an angiogram. No, he had a STEMI in the COVID period, and he was lysed. And he reached my cath lab in a stable condition. We did an angiogram, and that was showing triple vessel disease. Proximal LAD showed a calcific, well collateralized CTO, and 2 discrete lesions in the circumflex and right coronary artery. He had a lot of events after the first surgery. He definitely said, I really don't want to redo surgery, thoracotomy. He had infection and he was in hospital for 1 month. So even then I discussed with the team, the family and all. took off the CABG option from the table. So then we went ahead with a decision of multivessel PCI. In any other case, I would have attempted the CTO of LAD first, but he was not at all keen for surgery. Then I finished the circumflex and right coronary artery stenting, and then took after 48 hours with an antegrade approach. Here is the LAD. You can see here calcific proximal LAD with one of the diagonal filling, and after that tight calcific CTO there, and well collateralized. So as a protocol, we start with a field XT wire with a fine cross support, and went systematic wire escalation, and it went to the subintimal space. I tried my best for nearly more than 1 hour, and was continuously going to the subintimal space and going almost to the mid LAD. So the attempt was stopped. So there was definitely a distal tough fibrotic and calcific cap that I could not pierce. So there were some good collaterals we felt, and I was disappointed at this time because I could not deliver completely. And but then I promised him that we can do retrograde, and but in a month's time he had an angina episode and he wanted to do that fast, and we took him for a retrograde angioplasty. We tried to identify the collaterals. There were some collaterals, but in between the connectivity was missing, we thought, but still we thought we'll do try retrograde. We tried with a Fieldrex T R wire with a Corsair microcatheter support. I cannulated and tried wiring in multiple collaterals. Took almost 3 hours, and the wire was going into multiple levels, but not reaching the left anterior descending. Once it almost actually went to one of the chambers, and you can see on the right panel that the wire tip is freely moving. Then at this point I had to stop again. I explained him I may have to attempt an antigrade for final this thing, or if it doesn't work, then he may have to go for a off-pump lima or something. And I decided to try an antigrade again. And here you can see even the previous stump was not there, so only I had the calcium as a marker, so I started, but I could easily enter with a XTA wire and reach up to the same subintimal track that I created. I tried with fresh wires. I tried with a Gayatri and wanted to penetrate it. So Oncospro 12, I gave different types of curve and tried. Every time it was slipping from the distal cap and going into either on the septal surface or to the diagonal surface. And then I had to stop. So we stopped at that moment, and whoever was in the cath lab, we had a discussion. And my technician showed I have one more wire, which once in a while we use for a peripheral CTO angioplasty. This is a Stato XS20, which has a very high tip load of 20, and supposed to be having a very good penetration power. And it is definitely not meant for coronary intervention. But then since the distal coronary is seen very well, I thought I'll give a try. The problem with this wire is it just goes forward. You have no control over that. And when I penetrated, it penetrated easily, but then I tried to manipulate. It was not going to LAD, but it went to diagonal. And in the injection, I saw that it is subintimal again. But from there, I tried to carefully manipulate into the LAD, and at this point, it went to the lumen of the LAD. After that, I advanced the Corsair, then exchanged the wire, and you can see that the subintimal tissue, the proximal subintimal entry and the re-entry back to the lumen through that tough lesion. Predilatations were done, but the distal cap did not open properly even after repeated. Then I had to use a cutting balloon and then stented with one single stent. And finally post-dilated with balloons, and this was the final result. I could even get that diagonal preserved, and finally could perform the total revascularization. So this is the wire, Astato XS20. I have used it similar situation in 5 patients. In 4 cases I could recross successfully, and 1 case just went on to continuously into the false lumen and I abandoned. This has an extremely high penetration power and a support and torqueability similar to a Confianza. There is a 40-gram version also of this wire. So if everything fails for an anterior dissection and re-entry, sometimes you may use wires like this or a Hornet wire. And there has been reports of using electrocautery assisted re-entry where they connect a unipolar cautery to the wire through a microcatheter and can pierce the distal cap. So to conclude, such wires with a high penetration power can be used for a tough calcific and fibrotic cap if the distal vessel is clearly visible. And electrocautery has been seen in reports as another option. If everything fails, we may have to think about a new strategy, a very new one, think out of the box, but execute carefully, keeping safety as the most important thing, because it's a CTO. You cannot have a complication in such patients. Thank you so much for your patience.
Thank you, Shafiq, for that nice case. I thought when you came, I thought it would be another tower, but it turned out very nice, and
the satisfaction index of this case was very high because I had a personal attachment to the patient, and he expected total cure, and I failed twice. Then finally I could, and that was the thing that I selected this case.
Yeah, but the perseverance. How many hours of total procedure both times together?
In the first antegrade, 1.5 hours. In the second retrograde, 3 hours. And I did the second antegrade in the same sitting, another 1.5 hours.
Very nice.
It was lockdown period, so we had a lot of time that time.
Any comments?
Sir, the wire escalation methods that you used here was in the sense of field RXT, then to as
Gaia 3, Conquest Pro 12.
So by the time antegrade was about 3 hours, sir.
Antegrade around 1 hour because it was just going into subintimal, and then I stopped because I planned to take even for the retrograde. I waited for nearly 6 weeks because I may have to reattempt antegrade, so I wanted it to heal perfectly.
Any comments from the floor? There are no comments. We'll close.
Thank you.
Already
Thank you so
running
much.
late. Thank you, Shafiq, for that nice case.
Thank you, sir.
Thank you, sir. May I invite the next set of chairpersons, Dr. Anil Kumar, Dr. Bijumon, Dr. Mahesh Kumar Nalin, and Dr. Saji Subramanian. May I request the speakers to kindly stick your scheduled time. We're running about half an hour late. May I also request the chairpersons to kindly help the presenters with their timing. May I also invite Professor Venugopal to kindly co-chair the session, please. Thank you.
Thank you. I think we'll go to the next session, that is the newer concepts in practice. I think for an old person like me, it's very interesting to hear what is new. So, and I have a very right person to my left, Dr. Mahesh. So let's start with the first talk, that is arterialization of the venous system in No Hope PAD. Dr. Shifas Babu.
Good afternoon, respected teachers, persons, and my dear friends. My topic is arterialization of venous system in No Hope PAD. So peripheral artery disease having a prevalence of 3 to 10% general population and 15 to 20% among those over 70 years of age. 5 to 10% of PAD patients aged over 50 years will develop chronic limb-threatening ischemia within 5 years. So CLA is defined as an AB of less than 0.4 or angle pressure of less than 50 for rest pain and less than 70 mm of mercury for tissue loss. Toe pressure of less than 30 mm for rest pain, less than 50 mm for tissue loss, and transcutaneous partial pressure of 4 to less than 30 mm mercury. But clinically, it corresponds to the Fontaine classification stage 3 to 4 or the Rutherford classification categories 4 to 6. So without revascularization, these patients will have a 30% annual risk of amputation, mortality rate of 20% at 6 months, 50% at 5 years, and 70% at 10 years. And more than that, if you are looking into the quality of life, these patients will have less quality of life compared to other chronic illness like cancers, chronic heart disease, and chronic kidney disease. So what's the problem in CLA? This can be a transmission failure, that is large artery disease, or a distribution failure, small artery disease like plantar arch, metatarsal digital branches. Up to 20% of patients with CLI are not candidate for revascularization due to lack of an arterial target for distal runoff or an appropriate conduit for surgical bypass. So this patient will have a desert foot, angiographically described as lack of both plantar arteries, plantar arch, dorsalis pedis artery, lateral tarsal arteries. So we usually manage conservatively with the postnode, spinal cord stimulation, intermittent pneumatic compression, hyperbaric oxygen therapy, neovascularization using gene and cell-based techniques, lumbar symplectomy, but all lacks strong evidence to support their widespread use. And amputation is often inevitable in No Hope CLI, and it is associated with a higher mortality rate than either form of revascularization. And sad part is 73% of patients who undergo primary amputation do not get an angiogram, and 54% patients do not get an intervention to restore blood flow. So coming to venous arterialization, this is actually an old concept, first described by Franconis Frank in 1894, but it is not popularized because of poor rate of wound healing and limb salvage as well as congestive heart failure and severe extremity edema. Later it is modified by Scheel in 1977 and Halstead and Vaughan in 1912. So here what we are doing is we utilize the disease-free venous bed as alternative distal arterial conduits and performed using a venous conduit placed between most distal patent artery upstream and a vein or foot or angle downstream by an end-to-end or end-to-side anastomosis, followed by side branch ligation and valvotomy. And it increases the blood flow in existing collateral vessels with retrograde flow through the capillaries to improve tissue perfusion and promote angiogenesis. And physiological data also showed that improved microvascularization in target skeletal muscle as early as 11 weeks and reduction in ischemic markers as well as venous lactate. So overall investigations into physiological mechanisms suggest success in arterializing the deep venous system with subsequent improvement in distal perfusion. And coming to venous anatomy, we have a lateral marginal vein and medial marginal vein dorsal aspect of foot and middle plantar vein, lateral plantar vein, the plantar aspect of foot. These are connected by multiple venae committents. An adequate pedal venous anatomy is defined as patent venous vessels of at least 2 to 3 mm diameter on the dorsal and plantar surface of foot, no thrombus, and ability to be compressed at the time of ultrasound. So we have 3 modes of venous arterialization. One is open, that is surgical. Second one is hybrid, and third one is percutaneous or transcatheter method. And in open method or surgical method, actually, from the artery into the vein, anastomosis is done with a cephalic vein or PTFE grafts. And this is approximately 5 to 7 days after the procedure. Proximal aspect of the veins ligated to prevent steel from the foot, and followed by typical wound care adjuncts. And we need a valvotomy to facilitate antegrade flow, and with the multiple techniques like retrograde balloon catheter, dilators, or valvotomy, cutting balloons, etc. And in hybrid method, the arteriovenous bypass is done with the conventional surgical method, and subsequent valvotomy or embolization of collateral venous branches is done with an endovascular approach immediately or in the following ways. Like this in this example, we can see a collateral vessel draining the arterial venous flow into the deep vein, then going into the plantar vessel. So that collateral can be coiled with the percutaneous approach. And coming to percutaneous, where we interventional cardiologists are more concerned, it is done with a system known as limb flow system or percutaneous deep vein arterialization system. Here, this system is consists of a 7 French compatible arterial catheter, 4 to 5 French compatible venous catheter, and arterial catheter needle, antegrade valvotomy, stent graft, both straight as well as tapered. Ultrasound guided venous puncture is taken in the foot, most commonly medial plantar vein, and the venous catheter is advanced through the medial plantar vein into the positible vein most commonly, and antegrade catheter is advanced from the femoral artery, and we can take a dual injection to to assess the crossover point. And with the help of ultrasound or a snaring mesh in the vein, the needle is directed and punctured from artery into the vein, and through the vein, through the needle, a O1/4 wire is advanced in the vein, and it is snaring out through the venous catheter. And that crossover area is dilated with the balloons, followed by a valvotomy, followed by placement of stent graft. And successful venous arterialization means more distal anastomosis, superficial recipient venous blood rather than deep venous system to prevent cardiac overload and lower limb swelling, wall destruction to allow forward flow. And what's the outcome data? In one paper, 41 non-option CLA endovascular versus hybrid study, at 1 year, VA primary patency was 28.6%, secondary patency was 67%, and overall wound healing at 1 year was 46%. And limb salvage survival probability at 1 year was 81%. There are two landmark trials. One is PROMISE 1 trial with the lymph flow system, 32 patients, 6-month and 12-month amputation-free survival was 74% and 70% respectively, and wound healing was 67% at 6 months, 75% at 12 months, and reintervention was 52%, and no instant restenosis in this study. And recently, 2 months back, PROMISE 2 trial published, 105 patients with a chronic limb-threatening ischemia, median age of 70 years. The composite primary endpoint was amputation-free survival. Amputation defined as freedom from above-ankle amputation and or death from any cause at 6 months. Technical success was 99%. The posterior artery was the most common target for AV crossing location, 75.2%. And median procedure time was 199 minutes, around 3 hours. So it's not a short procedure. Anyway, it's a no-hope situation, so it's okay. But at 6 months, primary patency was 25.9%. Secondary patency was 64%, amputation-free survival was 66.1%, and target wound were completely healed in 25% at 6 months, and target wound in the process of healing in 51%. So take-home message, arterialization of vein is a promising treatment option in no-hope CLI. Surgical and transcatheter techniques are available with the promising outcome data, pain relief, wound healing, and limb salvage. So no-hope is now having some hope. Thank you.
Thank you, Dr. Shivas. Fabulous and very new topic that we've discussed. 2 points. One, all your studies finished at 6 months.
Yes.
I'd like to know what are the 5-year follow-up.
The prior trials, one year data is there from the surgical and hybrid technique. This lymph flow only 6 months data is there.
Secondly, even if you're doing this procedure successfully on the leg, just making one conduit won't solve the problem. You'll have to make multiple conduits. And where it has been used very successfully for more than 5-year period, success is when you're making an arteriovenous graft for dialysis in the forearm. Worked wonderfully and this is being used. What is your experience? Have you any experience with that? Making AV fistula in the forearm using this technique, percutaneous?
No. AV fistula for dialysis using this technique.
Yes, sir. Actually, there is techniques available with the different system, not this lymph flow, but that is actually, I think it's a laser-based technique, I think. But all the problem is cost.
Any comments or questions on the floor? No, you need to have, Shifas, you need to have good venous system.
Yes, sir.
Very often what happens is people with peripheral vascular disease, their venous system also tends to be, they have edema and you will have problems with that veins also.
Yeah, and radiologists should be aware of this condition and they have to assess the veins.
It's an emerging technique, but it associated with a lot of problem. I think there has to be a learning curve in this.
Yes, yes.
If there are no further questions, we'll go to the next topic.
Shifas, what you said, the results are for the non-surgical method, no? Surgical method, do they do multiple conduit connections? Surgical?
Surgical method,
do they do multiple, all these connections, arteriovenous? No.
No, they usually they will place a one venous
One
graft only
major.
into the distalmost venous target. And they have to cut the all collaterals, everything, because we have to direct the flow into the superficial plantar vessels, plantar veins. Because if there is collateral vessels, the flow will go through the deep vein into the system. So, no.
They do in the major vessel. No?
Yeah.
Thank you, Dr. Shivas. We'll move on. Fabulous presentation. Now we have the next talk on planning of mitral interventions in heart failure, indications and timing by Dr. Hari Krishnan. I'm looking forward to this talk because the last patient I sent came back. So now I know when, after this talk, I'll know which patient to send across.
Good afternoon, and thanks Dr. Jayagopal and the organizing team. We know that secondary or functional mitral regurgitation occur in around 30% of the patients. Whether it is ischemic or non-ischemic, that leads to LV remodeling, which reduces the mitral valve leaflet coaptation. That is the main mechanism of secondary MR. And we know that MR begets MR, and it is a vicious cycle. So the mechanisms are basically, it's a tug of war between the closing forces and the tethering forces. Papillary muscle displacement, annular dilatation, maladaptive leaflet thickening, and fibrosis are the major mechanisms. How will you assess the patient? Initial assessment to assess the clinical severity of heart failure, ECG to look for ischemia, QRS duration, coronary angiography, either invasive or non-invasive, to assess the status whether we can improve the LV function. Echocardiography is the cornerstone. But LV function assessment in the presence of severe MR, we know that it has limitations, and GLS may be a better assessment. TE, whenever feasible, it should be attempted. And we should also know that whenever you assess with TE, we should know the effect of sedation, stress during TE, which can change the mitral regurgitation significance. Severity of MR, we should do a integrated multi-parametric approach. The ESC recommends 3D imaging should be used whenever feasible. And we always should remember that secondary MR is a dynamic thing, varies with the loading conditions. You have to assess it when the patient is stable. The decompensated patient, you have to stabilize. Therapy should be optimized, and BKP should be controlled. The criteria for assessment of severe MR varies. The 2017 ESC and the ASC guidelines varies. For example, the secondary MR, it is more than 20 effective regurgitant orifice area, but it is 40 in the other two guidelines. Also, the regurgitant volume is 30 and 60 in the two guidelines. This is, we will discuss. Okay. This we will discuss when you discuss about the two trials in MITRA-CLIP. The limitations in severity of MR assessment, we have already told. Because the effective regurgitant orifice area, the total forward stroke volume is lower than the because of the lower estimated regurgitant volume. And we always assume it is the orifice to be circular when we assess the PISA, but we know that many of the times in a secondary MR it is an elliptical orifice, and multiple MR jets can complicate the issue. Other parameters are usually assessed. I am not going to those details like leaflet coaptation distance, tending height, tending area, etc. How to manage secondary MR? We know that even mild MR is prognostically significant. But surgical intervention of even moderate MR is not, or any intervention of any moderate MR is not beneficial. But severe MR benefits significantly by intervention. So we have to identify those patients with severe MR. And it should be by a heart team. So we have to give the pharmacological therapy for heart failure. RNA has been found to be better than ACE inhibitors. TRT, whenever feasible, it has to be done because it has found to show found that intraventricular dyssynchrony precipitates secondary MR, and it has been found in large RCTs that a CRT improves the secondary MR. Coronary revascularization, it has been found that following isolated CABG, MR improves in around 50% of the cases. Percutaneous coronary intervention, the data is not that robust. What is the latest recommendation on ESC, the 2021 guidelines? Now, when the patient is have a chronic severe secondary mitral regurgitation, valve surgery or intervention is recommended in patients with severe secondary MR who remain symptomatic despite
guideline directed therapy, including CRT or whatever. Patients who have CABG, it's a class 1 recommendation to do valve surgery along with CABG. Symptomatic patients who are judged appropriate for surgery by the heart team, the class 2A indication for considering MitraClip or an end-to-end procedure. The MitraClip procedure was a class 2B indication, now it has become a class 2A indication in the 2021 guidelines. These are the criteria for the predictors of outcomes with MitraClip. I am not going to those details. We have cases where we will have a very good outcome and cases where it will not be beneficial. This is called a COAP criteria. When should you intervene? We should understand that when the LV dilates very significantly, the significance of mitral regurgitation in the prognosis will not be, the severity of MR will not matter because the heart is already remodeled. So once the LV has remodeled significantly, it will not benefit. So we have to identify patient initially before the LV remodeling. For example, when the effective regurgitant orifice area is less than 30 with advanced LV dilatation or dysfunction, it will not help. Surgical options, mitral valve repair with an undersized complete rigid ring is the choice. Repair versus replacement, not much difference. Either you can go for repair or replacement. The long-term outcomes have been found to be the same. Now we come to the MitraClip. The two trials, the COAP trial which showed significant benefit and the MITRA FR trial which did not show significant benefit. We said that the difference is due to the selection in the patients and also because I said the 20 and 30 effective regurgitant orifice area and the regurgitant volume and the guideline directed therapy given in this group of patients and the technical success, all this mattered in these two trials. Recently, the COAPT PASS trial have been published, 5,000 patients which showed a very significant benefit at 1 year from the baseline. You can see that there is a significant benefit compared to the guideline directed therapy group. The 5-year COAPT trial data has been published in March 5. You can see that the benefit which has been shown initially persists even at 5 years. You can see that only the safety event is only 10% at 5 years. So that is a very safe procedure. There are other modalities also, like interventions also, like the coronary sinus modification. There are many devices. The reduced MR, which showed this particular Carilion device, showed significant benefit in a group of 120 patients. So in the secondary MR, to conclude, secondary MR occur in around 30% of the patients with heart failure with reduced ejection fraction. We know that even mild MR is prognostically significant, but intervention in mild to moderate secondary MR is not beneficial. You have to identify secondary MR before the LV has remodeled significantly, and severe MR definitely benefits. CABG plus mitral valve repair improves outcomes, so mitral valve repair should be combined with CABG whenever it is indicated. And MitraClip, the tier, benefits on short-term and long-term outcomes up to 5 years. And case selection is very, very important. You should follow the COAP criteria. Thank you.
Thank you, Hari. I think it's a very, very important group of patients that you are now coming, especially following interventions, coronary intervention and all. And this group really needs to be critically evaluated, because very often we find that by the time you refer for an intervention, the patient it's already a little late. The LV has dilated, there is significant LV dilated. So I think it requires a very clear idea about when to refer and what are the benefits.
Yeah, that is basically the message.
Crux of the message.
Two questions. One is, when would you prefer MitraClip over a surgical repair? Point number 2 is, even if the LV has remodeled, by doing a MitraClip, would you give a subjective class improvement in the functional capacity of the patient?
Surgical versus MitraClip, the class 1 indication is surgical. When severe secondary MR. When there is associated CABG, then also the class 1 indication is there. When it should be discussed with the heart team. And if the surgical risk is very high, then you have to go for a MitraClip. Still the class 1 indication is for surgical repair, and whether it is with associated coronary artery disease or not. Now from class 2B, it has come to a class 2A indication for primary mitral clip. But mitral clip is the cost is also one factor where it costs 25 lakhs or more in the Indian condition.
Remodeled LV?
Remodeled LV, it is said that if the ejection fraction is less than 15 and there is a significant non-viable tissue, then there is no benefit in going and you have to try all sorts of, go for the guideline directed therapy, maximum tolerated doses in 3 months' time if possible, and also try CRT and revascularization. If all this fails and still you have symptomatic MR, when there is significant LV, not very remodeled, then only mitral clip is.
Comments or questions? Thank you, Hari. I think it's a very, very important topic that you have excellently presented. We'll go to the next topic. That's choosing the right patient for cardiac transplant. Dr. Joe Joseph. Joe, I think, is the right person to talk to us on anything regarding cardiac transplant. Joe.
Good afternoon, chairpersons, teachers, my dear friends and colleagues. Always a pleasure to talk about transplant today we will be discussing about when to refer a patient for heart transplantation. Right now we got reasonable results with heart transplantation with the 10-year survival reaching something around 5-year survival is more than 70% and the median survival is around more than 10 years. So this is the usual patient we get for evaluation for a heart transplant. This is one of our own patients, a 42-year-old gentleman, artist by profession, severely dilated LV, severe LV dysfunction, diagnosed to have dilated cardiomyopathy and considered for effort for considering heart transplantation. Echocardiogram evaluation, there is significant STT, significant LV dysfunction, and 2D stain shows reduced deformation. So this is how we progress basically, assessment of the severity of the heart failure. And if you have an identifiable cause or a reversible cause for heart failure, you identify, treat it. And assess the severe adequacy of the current medical management. If the current medical management is not adequate, we have to optimize. And if possible, we can wait for a few months of medical optimization. And if there is no reversible cause is found, and in spite of the optimal therapy, if the patient still remains in class 3 and class 4 status, that's the time the transplant evaluation process begins. But you know, there is some contraindications like if the patient is in an acute heart failure and cardiogenic shock, and if the patient is on inotropic support, if the patient is on a temporary VAT support or temporary mechanical supports, that are these patients will not go will not fall into this category. And this is our conventional criteria for heart transplantation. We got both things should be there. That is the impaired LV systolic dysfunction with associated class 3 and class 4 symptoms. Patient should be receiving optimal medical management, that to the tolerated level. And if there is indications for ICD, CRT or combination of both, the patient should be on that. And it should be associated with the evidences of poor prognosis. And the poor prognosis can be considered by, one is the cardiorespiratory exercise testing, VO2 max, and if the VFD max is less than around 12 or 14. And if the BNP is increasing in spite of full optimal medical therapy, and you got scoring systems like the SHF heart failure severity score, as well as the Seattle heart failure model, and if there is high increased risk in these categories, this patient should be considered for heart transplantation. But there are some other patients, like these patients will consider around less than 5% of our transplant patients, where we got a patient who is having a significantly hemodynamically compromising ventricular arrhythmias refractory to all forms of therapy, like a patient with a refractory angina, which is also refractory to all forms of therapy, and patients with a restrictive cardiomyopathy as well as hypertrophic cardiomyopathy with significant symptoms in spite of medical management. And in spite of these patients less than 5%, among these, this will be the most common category patient with restrictive cardiomyopathy. This is a patient, one of our patients, a 19-year-old man, anterior wall MI, Kawasaki's disease, anterior wall MI, CABG, post-CABG, the inferior wall MI, subsequently PCA to circumflex, and
ischemic cardiomyopathy, there is no other options other than going for a transplant. But we should have some other clinical evidences for that. And I think I'll be following, these clinical parameters are more important than the theoretical aspects. One, if there is more than 2 admissions for a recurrent heart failure in the last 12 months, if the patient is having recurrent hospitalizations, and if there is clinical evidence of overt heart failure in spite of optimal medical management, if the scoring system shows high mortality, that is more than 20% mortality at 1 year, evidence of increasing RV dysfunction and increasing PA pressures, and anemia, involuntary weight loss, liver dysfunction, hyponatremia attributable to heart failure. These will be the 2 important things. What if the patient is having recurrent hospitalizations with heart failure, that to at least more than 2 per year. And this is the RV evidence and dysfunction as well as increasing PA pressures, because once the PA pressures has increased to a stage, the transplant mortality increases, the acute mortality increases, but there is no significant changes in the long-term prognosis that we will come later. And these are some other things, like if the patient is having deteriorating renal functions in spite of diuretics, and we want to increase the dose of diuretics to clear the congestion without change in renal function. Significant episodes of ventricular arrhythmias despite full drug and electrophysiological treatment, and increasing levels of BNP or NT-proBNP level despite adequate heart failure therapy. These are the clinical parameters we should consider before referring patients for transplantation. For any procedure, we will always think of what is called as the absolute contraindications and relative contraindications. I think there is in transplantation, there is no absolute or no relative contraindication. We have to think of multiple parameters, what I will discuss as the exclusionary considerations. The most important thing is the pulmonary artery hypertension. Irreversible and fixed PAH with the maximal medical and mechanical therapy. If the patient is having irreversible as well as fixed PAH, in spite of all this therapy, it's a relative exclusionary criteria. And this is the most important thing. If the patient ideally should have a systolic PA pressure less than 50, the transpulmonary gradient should be less than 15, and PVR less than 3 to 4 Wood units. And subsequently, some other considerations like it should have irreversible end organ damage, irreversible pulmonary disease, peripheral vascular diseases, malignancy, psychiatric diseases, obesity, substance abuse. These all parameters should be taken into consideration before referring the patient considering the patient for a transplantation. And elderly patients with osteoporosis, because most of the drugs will produce osteoporosis. These are all exclusionary. We should think of these parameters also before referring the patient for transplantation. Regarding the non-compliance, psychological as well as social status, the financial status also is very, very important, because the patient may do a transplant with the help of some charitable organizations collecting money, but post-transplant follow-up will most of the patients become also a financial burden, and we should always think of the financial considerations before sending the patients. Regarding the viral infections, hepatitis B, hepatitis C, and hepatitis HIV, these are not absolute contraindications. Depending upon the viremia and the chronic liver status, we should take the decisions. Then, considering the age is also an arbitrary, and in a very practical sense, in our guidelines, then our patients will say it is not wise to do a transplant for a patient more than 70 years. What we think of is something like a 65-year-old, 60 to 65. But in the Western countries, they are doing transplant even more than 70% of the patients. 70 years of patient. So most important consideration is we should think is the pulmonary hypertension, because that's the only absolute contraindication. If we have got an irreversible and fixed pulmonary hypertension, it's an absolute contraindication. So for that, it's a right heart catheterization is mandatory with the measurement of systolic PA pressures and TPG. And if the TPG is less than, TPG is mean PA minus the pulmonary capillary Givet's pressure. If it is less than 12, it's a safe to do transplant. If it is more than 2, we need to assessment of the reversibility. And there are caveats regarding reversibility assessment. In patients with pulmonary hypertension and without pulmonary hypertension, if the patient got a reversible pulmonary hypertension, These should not be left alone or denied transplantation. They got a similar outcome in patients without pulmonary hypertension. So we have to be very careful in these patients, and these patients should be adequately treated and with vasodilators, pulmonary vasodilators, sildenafil, etc., so that their pulmonary hypertension decreases and these patients can be subsequently transplanted. So initially we got a high TPG. That should not be the exit point. We should treat these patients with pulmonary vasodilators and reassess the patient, and subsequently we can safely do a transplantation. This is a study where there is the they tried the acute vasodilator response with the sildenafil. Around 38 positive patients, they got they given vasodilators, and they found that their survival is almost similar to patients with pulmonary no PAH. So there are some issues with the TPG because it's a which number 12 or 15. What's the effect of concomitant medications? Which is the best way to assess reactivity? Which is the best molecule? Which is the best? And regarding the side effects. So don't go by a single number. Do vasoreactivity, optimize medications, and recheck before delisting the patients. So there is no consensus regarding how to address pulmonary hypertension in patients with transplant centers. There is no consensus. And the studies have found that if the patient got a pulmonary hypertension initially, if the pulmonary hypertension is there is no significant difference between the long-term outcome. It is basically the 30-day mortality because of RV dysfunction. So the patient has to be taken well care within the first 30 days to prevent a mortality. After if the patient is tied over that acute crisis, definitely there is no significant difference in the survival. So this is one of our patients. Initial echo showed very high TPG, put on optimal medical management, recheck echo, and if finally we did the TPG again, it was still high, so we have to delist this patient. So basically it's a teamwork, and we know that there is no absolute or relative contraindications. The most important consideration is the clinical considerations, and as well as the pulmonary hypertension, especially for the fixed as well as irreversible PAs. This only contraindication. And if you do it, it's basically a teamwork, and all the members of the team plays a very important role. Thank you so much.
Thank you, Joe. It's a very interesting, excellent talk on identifying patients for heart transplant. You have highlighted the importance of pulmonary hypertension and how to assess, go about pulmonary hypertension, deciding operability in patients with pulmonary hypertension awaiting transplant. Any comments or questions?
Wonderful talk as usual. 2 points. One is, നമ്മുടെ പ്രബുദ്ധ കേരളത്തിലെ donors are very less. The education of the general public and the doctors and a few movies have contributed significantly in reducing the number of donors in Kerala. Surprisingly, Tamil Nadu, if you go, the number of donors, in North India, even in Maharashtra, the number of donors are phenomenally high. So we need to wake up.
No, is that correct? Because when I was in medical college, of course that's 5 years back, I was told that there are plenty of donors but not enough recipients. So the question I wanted to ask was, when I was in medical college, I had 3 patients who I listed for transplant. But all 3 died within 2 days, so I could not refer them for transplant.
That is the second point I was trying to say. Our team is a very painstakingly brought up, from the JR to the senior surgeon, to the anesthetist, to the transplant pathologist. Everybody has to be in one gel, and you have to work together for years to make a team. Just bringing in an ad hoc team to do a transplant and prove that you have done a transplant, get paper news, and then after that, no news about what happened to the patient or to the center. Unfair. If you're doing it, please do it sincerely, like this team is doing, like probably the Chitra team should be doing. Take that as examples. So 2 points out.
I think as we are running short of time, I think we'll close this session. Thank all the speakers for their excellent presentation. Thank you so much.
Thank you, sir. Move on to our next session on contemporary issues. May I request the chairpersons to kindly take their seats on the dais. Dr. Bhim Shankar, Dr. Matthews Paul, Dr. Paul Thomas, and Dr. Rajalakshmi, please. First speaker, Dr. Rajat.
Good afternoon, everybody. Here for some contemporary issues, we'll have Dr. Ajit to tell us about what's new in CID infections.
So, good afternoon, respected chairpersons and all friends and seniors in the audience, and thank you to the organizers. So, let me get started on the topic. It's a simple but I think a very relevant topic. Concepts in cardiovascular implantable electronic device infections. Now, what is the true incidence? The older pacemaker registries, they include only pacemakers. They said that the incidence was somewhere around 0.5% for the first implant and about 1.2% after the second implant. And there have been reports of rising trends. Mainly from the US National Database, it says that the rate has increased all the way from 1% to 3.4% over a space of 12 years, and the rise in complex implants like CRT, CRTD is much more. Now, I put it here, this is the retrospective analysis of registry. What is frightening is the outcome. It's associated with significant mortality and morbidity and cost. To extract one lead would take about 3.5 to 4 lakhs. And if it's 2 leads, it will take about 5 lakhs. So that's far more than the cost of whatever device we're implanting. And the mortality doesn't stop with the explant, it's much more. Now, considering that about 1.5 million devices are implanted per year across the world, these numbers are frightening. But there are 3 sides to every story. Is that data correct, what we just saw? None of the prospective registries show a dismal picture like that. Those are retrospective. You can imagine if you have a retrospective registry of 4 million patients, you can imagine how good that registry would be. I mean, there's good and bad to it. That US registry is 4.1 million patients, retrospective. The prospective registries say that the control group, the infection rate is about 1%. This is including all types of implants. This is the control group, not the treatment group. And hardly any difference between the treatment group and the control group. If you take smaller single centers, it's even less. The best single center follow-up I could get was the Northern Italian database with 99.4% follow-up. They report a 0.5% infection rate. I have not seen that much rate, to be frank. I don't think many of us have seen this much rate. I have personally implanted about 2,200 implants in our center in the last 10 years. I know that it's not a 100% follow-up, but 3 patients have come with an infection. One was a post-operative patient who had shock for ventricular tachycardia, was put back on a ventilator. Unfortunately, his urine already had MDR Klebsiella at the time we were putting the ICD. We were not aware of the culture report. The culture report took time. 3 weeks back, 3 weeks later, he came with a bloodstream Klebsiella and a device Klebsiella, and took the device out. The second was a patient who had a dual chamber pacemaker on the right side. I knew the RV lead was in trouble, so I wanted to change the RV lead. On table, I found that the RA lead was also not working well, so I ended up putting 2 new leads in the presence of 2 old leads, and that patient also got infected. The third was a patient who had a fractured ICD lead, which was implanted 8 or 9 years back. I put in a new lead. I couldn't extract the old lead because of adhesions. I left it there. I put in the new lead. And 2 months later, he came back with the infection of the new lead and the old lead. And I had to extract both of them. And he went home, but he died 3 weeks later. I don't know why he died, but people do have higher mortality even after the infection. So I don't think the picture is as dismal as the literature paints it out to be. But we can't really ignore this database. Like you said, when you have a database of 4.14 million patients, you cannot ignore that. And what you can't ignore is that the infection rate among complex implants is definitely increasing. I'm not really sure which absolute numbers to believe, because personally I don't think the absolute numbers are this high, but definitely the infection rates of absolute complex implants are high. And this is what the database would say. CRT or CRTD 8 to 9 per 1,000, I don't believe that. ICD, subcutaneous versus transvenous, the infection rate is the same, but subcutaneous, you don't have a bloodstream infection, so it's easier to manage it. Device replacement slightly more. Transvenous pacemaker, I'm not really sure what's the true rate. I think it is well less than 1%. Leadless pacemaker is near 0, but the problem with leadless pacemakers, anybody who currently requires atrial pacing or is likely to require atrial pacing in the life of the device, which is about 10 to 12 years, does not qualify for a leadless pacemaker. So there aren't too many patients who
require a leadless pacemaker. If a dual chamber leadless pacemaker would come, it might probably change the scenario regarding device infection. So that's about the incidents. Now, what are the factors that cause device infection? I think we should pay particular attention to the second part, which has prospective studies, but prospective studies have not looked at all the factors. One factor that is right on top of every list is ESRD, or renal failure. And then these are many other factors which are obvious. History of device infection, fever, but I want to take your attention to this. Oral anticoagulation, it does not predispose to infection so long as your INR is about 2 to 2.1, 2.3 range. Use meticulous cautery, meticulous hemostasis, it doesn't predispose to any infection. So if a patient has had a metallic valve inside there, don't stop the anticoagulant because you want to put a device. But this is the slide I want to highlight. Most of the factors are controllable. The biggest factor for infection is procedure duration. It's a long procedure. Especially if during the long procedure, as people are prone to do, you open and close the cath lab door and people keep walking in and out. The one thing that I do when the procedure starts is the door is locked. If it's a 5-hour procedure, it's a 6-hour procedure, let it be. The door stays locked for 6 hours. Nobody goes out, nobody comes in. If it's a 6-hour procedure, you plan the whole hardware and stay inside. So I think the one thing that makes a difference is the procedure duration. Preventing a hematoma. Make sure that you don't have to reposition any leads. These 3 things will make the biggest difference. Fortunately, these are all controllable factors. It is recommended that the operator should have an experience of at least 100 implants and at least 50 implants per year. That is the standard recommendation. Can we predict it? There are certain predictive scores. These are basically similar to what I just told. Complex devices, revision, renal insufficiency. A score has been made based on this is padded score. And what causes it? It's almost always Staphylococcus. So don't try to give meropenem and don't try to give all of those gram-negative antibiotics. It's almost always Staphylococcus. Across the world, North America, Europe, Asia, it's Staphylococcus. Early infections of Staph aureus, and late infections of Staph epidermidis. Almost always it's that. So make sure you cover that one organism. The gram-negatives, yes, they're there, but they're far less. And can we prevent it? Yes, by using very simple methods. Do not put the temporary pacemaker, please. Unless it's absolutely necessary, please don't put the temporary pacemaker. Okay? And remove all central lines before the patient is taken into the cath lab. Make sure the place is sterile. Make sure that the skin is cleaned well. Make sure the patient is scrubbed multiple times. Don't use a razor to clean the skin. Use clippers. Okay? Make skin wash. We make the patient bathe in antiseptic solution at least twice before the procedure. We give the chlorhexidine solution, tell them, take a bath with this previous night and next day morning. And we make sure that the scrub is given 1 hour before shifting for the procedure. Very simple thing, but very effective thing. We also make sure that the cath lab is hand cleaned. Fumigation doesn't work. It doesn't matter. It takes us 1.5 hours to prepare the lab. It takes us less than 1 hour to do a procedure, but 1.5 hours to prepare the lab. Everything in the lab is hand cleaned with an antiseptic solution. All cables, all wires, the entire C-arm, the entire II, everything is hand cleaned with an antiseptic solution. Antibiotic prophylaxis makes a 45% reduction. It doesn't matter whether you give higher antibiotics. It has been prospectively studied. Cefazolin alone is sufficient. Adding vancomycin doesn't help. Adding a gram-negative doesn't help. I used to give cefazolin. Now I give piperacillin because I think I'm becoming a little more fashionable. I really can't find a logic for giving piperacillin. I'm giving piperacillin now, but I used to give cefazolin till 2-3 years back because I got 1 gram-negative infection. That's why I changed to piperacillin. So, and very important, once the antiseptic is painted on the skin, give it at least 10 minutes to dry. The usual contact time for povidone iodine is 10 minutes. It will be written on the bottle. What is the contact time for that particular? So it's usually 10 minutes. So before each scrub, let it dry there for 10 minutes before putting on the next coat. And at the end, always clean with alcohol. A surgical preparation with alcohol is required. It's a very, very simple thing, but these things are very, very important. Okay? And maybe if you want, if the patient can afford the 85,000 envelope, you can put that 85,000 envelope. So that's it. And if it is an infected, please remove everything. The policy of cutting the wire and taking the wire out, leaving it there, hoping that it will work, it doesn't work. Plus, it makes a future lead extraction impossible. If you do that and it's infected, then it's a sternotomy and opening the heart. So please, if something is infected, take everything out. It's as simple as that. So, yeah, I won't go into the criteria. They're way too complicated. I think it's fairly logical. You can figure out if a device is infected or not. The conclusions, simple but rigorous precautions can still prevent CAD infections in most situations. Antibiotic for methicillin-sensitive staph aureus should be administered within 1 hour before the procedure, not 2 hours before. It should be within 1 hour. You should make your skin incision within 1 hour of administering the antibiotic when the antibiotic concentration is at its peak. If by some chance it's late, I tell them to give one more antibiotic just before I give the incision. This is obvious. Renal failure, immunocompromised patients, prolonged procedures, lead revisions, complex implants, hematoma, they will predispose to infection. A Tyrex envelope may be used in some patients, and infection requires removal of all material. Thank you.
Thank you, Dr. Ajit. That was a wonderful talk covering everything. After the prophylaxis, do you recommend following up for a few days antibiotic? Prophylaxis
Again, a controversial thing. I give antibiotic for 48 hours. Literature has found that post-procedure antibiotic is not required. Literature has found that zero post-procedure antibiotic. Some things are ingrained in our minds. Literature has shown that instilling, cleaning the pocket with the gentamicin or instilling antibiotic in the pocket doesn't make any difference. But some things are in our habit, and since it doesn't seem to cause any harm, we do it. I give it for 48 hours. Literature says it's not required.
Sometimes in very elderly patients, like some 97-year-old lady, actually the lead, after the replacement of the generator, she developed infection, and that lead was not able to, we were not able to extract. And she did well with antibiotics.
Why do you want to extract? Okay, you mean for an infection?
The lead also got like endocarditis.
No, you mean there was an infection and you couldn't extract?
Infection. Pocket infection.
Yes.
For a replaced generator, and that the blood culture was positive, and the lead also were having
Yes, so in that situation, what has been done is what orthopedicians do. You can give a continuous infusion of antibiotic, put antibiotic beads in the pocket and try a continuous infusion. It has been tried. Orthopedicians do that for infected implants.
I think you answered that question. I was about to ask that. In fact, I saw this thing where, you have a continuous when it's infected.
Yeah, it has been. It's painful. It has been done for something like 2 to 3 weeks.
But does it work? I mean, it's been
a small study
propagated.
says that it works.
But I think
Orthopedicians say that it works in infected implants.
the recommendation is to extract.
Yes, the recommendation is definitely to extract. One study just came up saying that it may be tried in patients where extraction cannot be done. That's why I said that in answer to that question.
Just one last question. What's your uptake on Tyrex? How often are you using it now?
I never used it.
So how often you have to drain the hematoma to prevent an infection?
Never drain a hematoma. That is one of the things that was in red. If there is a hematoma, don't drain it. The hematoma is sterile. You put a needle in it, it becomes infected.
I just want to make one point that there are 2 guidelines for scoring about whether lead extraction is safe or not. I think one was in 2017 and the other was in 2018. So that's how important lead extraction is considered to be. 2 guidelines.
This really depends on the experience of the center and the team at lead extraction. There are very few teams and centers experienced at lead extraction. It needs a tremendous amount of experience. It needs to be done in the operation theater in a hybrid OT.
Thank you, sir. We are running short of time. Next, I would like to invite Dr. Jayaprasad, the additional professor, MCH Kottayam, to throw light on newer trends in infected endocarditis.
Good afternoon, respected chairpersons, respected teachers and dear friends. I thank Jay Gopal sir for giving me this opportunity. So my topic of presentation is infective endocarditis, the changing trends and management. This is the overview of my presentation. As you all know, infective endocarditis has an expanded spectrum in recent times. It can involve any structure ranging from native valve to pacemakers to LV assist devices, septal occluders, everything can be involved. and the epidemiology is also changing. In fact, this one disease, one of the cardiac conditions that is increasing in incidence. The prevalence of infective endocarditis is increasing, and in some countries it has even doubled in the last 10 years. And the in-hospital mortality is around 15 to 20%, which is very high, and 1 year mortality is approaching 40%. Even though there is advances in management as well as a diagnosis, that has not converted to a prognosis, a better prognosis in infective endocarditis. And the increase in incidence is largely attributed to the growing population with chronic comorbidities, increase in drug abuse, and an increased need for invasive procedures and implanted devices. Is there a relation between the increase in incidence and the stoppage of antibiotic prophylaxis for dental or other procedures? This is a large insurance-based data from US, which shows that around the time of stoppage of antibiotic prophylaxis, that guidelines in 2007, there was an increase in the incidence of endocarditis in high risk, as well as a mild increase in moderate risk patients. But still the guidelines continue. In the latest 2020-21 guidelines, the AHA advised prophylaxis only for high risk patients because there is no definite data showing an increase in the prevalence of oral streptococcus infective endocarditis. Microbiology of infective endocarditis is also changing. Now you can see that almost all types of infective endocarditis, the most common organism is Staphylococcus. Another vexing problem of infective endocarditis is culture negative endocarditis. You have many options now. Apart from the prolonged incubation, you can have a viral culture or histologic evaluation, serological assay for these organisms, and molecular methods, particularly the PCR of blood PCR as well as viral PCR, and metagenomic next generation sequencing, which is coming as a future technique in culture negative endocarditis. In some studies, it has shown almost 90% yield in culture negative endocarditis. But the problem with these techniques is the lack of availability and cost. Another recent incorporation is the multimodality imaging in infective endocarditis. Even the European Society guidelines has included the FDG PET scan as well as CT scan findings into the major criteria of modified Duke's criteria as a major criteria, and this helps in upgrading many of the possible infective endocarditis cases to definite infective endocarditis cases. MDCT is particularly useful to identify the perivalvular complications, mycotic aneurysms, and also for preoperative coronary assessment. Nuclear imaging, including FDG PET scan, is very useful for prosthetic valve endocarditis. But the problem is with the initial 3 months, it may give a false positive result because of the non-infective inflammation. And in one study, it has helped in recategorizing 76% of patients with the prosthetic valve endocarditis from possible to definitive infective endocarditis. This is a picture showing the FDG PET scan along with the CT showing the pseudoaneurysm as well as the perivalvular abscess. Another imaging modality is a radiolabel WBC imaging with a SPECT that can be used even in the initial periods after prosthetic valve implantation. MRI is basically for cerebral imaging for complications. And all the guidelines now advise treatment by an endocarditis team that consisting of an infectious disease specialist, microbiologist, cardiologist, a cardiac surgeon, as well as a neurologist if the patient has neurological signs. And this incorporation has, this implementation of a multidisciplinary team has in fact improved the mortality of, in-hospital mortality of infective endocarditis in many studies like this. And in the treatment of infective endocarditis, the current trends involve outpatient parenteral antibiotic therapy and outpatient oral therapy. Outpatient parenteral therapy is for uncomplicated Streptococcus bovis infection, after the critical initial 2 weeks. Partial oral antibiotic therapy of infective endocarditis has become a new trend in the treatment after the publication of this POET trial. This trial was included patients with left-sided endocarditis caused by Streptococcus, Enterococcus, Staphylococcus, all those organisms. After 10 days of appropriate antibiotic treatment, the patients were routed to the oral therapy. At least 1 week of appropriate parenteral therapy should be done after valve surgery. And patients should be free of any signs of they should be afebrile and C-reactive protein should be less. And the result was that the all-cause mortality and other events were non-inferior to intravenous treatment with the oral treatment. Another controversy regarding antimicrobial treatment is the role of gentamicin and rifampicin. The studies have found that in staph prosthetic endocarditis, they are not not much additional benefit and having more toxicity. And Enterococcus endocarditis also, the combination of ampicillin plus ceftriaxone was equally or even better than ampicillin plus gentamicin with reduced complication rates. Surgical treatment of infective endocarditis is advised in these complicated situations. Even the European Society has advised urgent surgery in patients with severe valve regurgitation. This is a newer technique for debulking large infective endocarditis vegetation in the right-sided infective endocarditis vegetation or device-related infective endocarditis. This is an angiovac suction system which was initially used for removing thrombus or other materials from the venous system. This allows evacuation of the aspiration and continuous reinfusion of blood using the angiovac system for right-sided endocarditis. Few words about endocarditis after TAVR. Studies show that the incidence of endocarditis is almost similar after TAVR and SAVR. Overall incidence is about 0.3 to 2% per person, 100 person years. And the peri-procedure time has highest incidence. And these are the risk factors: young age, male sex, lack of balloon aortic valvuloplasty, and treatment in a catheterized laboratory opposed to hybrid operating room. In fact, infective endocarditis associated with the TAVR is having a higher mortality rate, and there are multiple sites of involvement also. And the sites of vegetation differs in self-expandable and balloon expandable valves, and the outcomes are dismal after infective endocarditis of TAVR patients. The serious complication occurs in 70% of patients, with in-hospital mortality in 16 to 64% of patients. And the management also, only a less number of patients, around 20% of patients were undergoing surgery, even though surgery was indicated in more than 50% of the patients, maybe because of the higher comorbidities. And another important point is Enterococcus is the most important organism, maybe related to the colonization in the groin region. Enterococcus was the most common organism causing TAVR endocarditis. So the take-home points: incidence of infective endocarditis is increasing and mortality is remaining high. Antibiotic prophylaxis guidelines still controversial. Proper microbiological and multimodality imaging is important for preventing complications. And management by an endocarditis team and prompt surgery may be indicated. And infective endocarditis after TAVR is a major concern with high morbidity and mortality. Thank you.
Yeah, Dr. Jayaprakash, that was a wonderful talk covering everything. Some vaccines are mentioned as newer concepts, no?
And there are some vaccines, but none of the studies have shown a definite benefit. So they are not advised in the guidelines, and no real randomized control trials are not available. Only some observational data are there. And there are some methods like biofilm formation, preventive methods by application of silver or other coatings in the devices like that. There are many newer things coming up, but none of them are proven benefit.
So if there are no questions from the floor, we'll close the session. Thanks. Thank you.
Thank you, sir. May I invite the next set of chairpersons, Dr. Anwar Varghese, Dr. Ravi Cherian Matthew, Dr. Sadat Parikh.
I'm happy to announce the winners of the poster presentation, the first prize, as well as the Best Paper Award. May I request Professor Sudhir Kumar, sir, I think sir only did the paper yesterday. For the best paper, best poster, award goes to Dr. Sri Gopal M. Prabhu from Medical College, Kottayam. Okay, Bhavan, sir. Sir, Bahulan sir, the second prize sir, please come. Dr. Sri Gopal, I think you're. And the second prize goes to Dr. Vrinda. Is Dr. Vrinda here? Somebody can take the prize on our behalf. Please come forward. Somebody from Chitra. Berlin, sir. Vrinda. We had a poster session, sir, for the first time. Congratulations. Now, may I now invite Professor Rajan Manjuran, Dr. Mohan, and the other two judges, Dr. Sajeevan and Dr. Ajit Kumar. I don't know whether they're here. The prize. Is the first prize, Harika? Vijay, Young Investigator. Sir, the Young Investigator Award selected by the judges goes to Dr. Bijoy Elias.
Kottayam Medical College show both the poster and the best paper award. Excellent.
Thank you, sir. I think we'll go to the penultimate session, right? Now we have the next session, which is Nightmares in the Cath Lab. May I request the chair, Dr. Anwar Varghese, Dr. Cherian Matthew, Dr. Sadat. Please. Bhavan, sir, can you go ahead? Dr. Sajeevan, can you just join the And we have the first presentation by Dr. Paul Thomas. Dr. Paul, I saw him here. Yeah.
Good evening, respected chair, teachers, seniors, and my dear friends. Story of a dislodged stent. This is how the story unfolds. A 45-year-old lady, the recent acute coronary syndrome known as stimulation MI, class 2 effort angina. She had underwent a PTCA to LAD and RCA 1 year back for an ACS NSTEMI. The present angio showed RCA ISR total occlusion. So the RCA was, the guide used was a 6 French JR guide. Initially we tried with a whisper wire, then upgraded to a field XT, then the Gaia one, and contralateral guidance, the lesion was crossed. This was the lesion after dilatation with a 1.25 balloon. And we thought of stenting right from the ostium till the distal landing zone, distal normal segment. And a 2.75 to 38 stent was deployed distally and was post-dilated with the 3.25 to 12 balloon at RBP. And another stent from the ostium covering the previous stent was placed 3 into 28 millimeters at RBP, and a 3.25 balloon was used for post-dilatation at RBP. After that, I am sorry for that. Another view is there. There was a distal haziness at the distal end of the distal stent, which was thought to be a distal dissection or a geographical miss or even a spasm. But after giving NTG, this haziness persisted. So it was decided to stent with a 2.75 28 millimeter stent, but that stent was not tracked. After the next injection, we thought that the lesion is okay. We'll plan medical management. Unfortunately, the IVS catheter, which was an OX1, could not be crossed, and the guide support was not that contributing. So after that, when the post-dilatation balloon was taken to flare the ostium, everything came out. The guide and the whole system came out, and we were alarmed by what we found the ostium of the RCA. The stent which we tried to track to the distal RCA was caught up in the ostium. And it was then only that the scrub checked the retrieved stent and found that it was only balloon. There was no stent in there. And we tried to pass a 1.25, one balloon through that. It was not going. The guideliner was not, you could not be tracked, because there was some kink in the guide catheter. So we rewired the RCA, and you can see the dislodged stent trapped somewhere in between the proximal and mid RC in the previous stented segment and floating into the aorta. And this was wired, and we thought of taking an end snare to snare the proximal portion. While it was sure that the dislodged portion was stuck somewhere in the proximal stent, so while we were pulling out the proximal stent, the ostial stent dislodged fragment, the proximal stent also may unwind and come. So we engaged the RCA and put a 3.25 balloon just for backup. So when the snare was able to pull the dislodged stent, we thought of dilating the osteoproximal RCA and keeping hold of the stented segment. But unfortunately, it did not work, and there was some traction on the proximal stent. So we tried with a bioptom, but the bioptom was not at all nearing the RCA, because when taking the JR catheter, the catheter was getting straightened because of the bulky bioptom. So after so many manipulations and so much toil in the cath lab, we switched to femoral, and to our alarm, it was seen that that fragment is not seen in the RCA. So we scanned the whole body and found that the dislodged segment was somewhere was located in the left renal artery. So, but we had to complete the RCA because we have a deformed stent in the RCA. So we rewired the RCA again, did serial dilatation with 1 millimeter balloon, 1.5, 2, 2.5, 3 and 3.25. After serial dilatation, we performed an OCT to size the vessel and see how much the deformed fragments are sitting inside the proximal RCA. And we had an ugly picture of the proximal RCA, the deformed stents. So we thought of plastering the stent with another stent. 3.5 into 40 millimeter long EES was deployed. This time we didn't repeat the mistake. We took the guideliner with us, and the stent was tracked through the guideliner only. And it was deployed at RBP, and a post-dilatation with 3.5 into 12 atmospheres was done. At 24 atmospheres done. And the post-procedure OCT showed an excellent result. All the segments were plastered and we had an excellent MLA. And next we proceeded with the retrieval of the renal fragment. First we tried used a sinus wire in the RCA in the left renal using a JR. And, because of the seating and it could not be delivered, so a single loop snare could not be delivered. So a triple loop, three loop snare, end snare was taken, and we had to take out the sinus wire, and with the help of the renal diagnostic catheter, we pulled the distal fragment. And in fact, there are 2 fragments in the left renal artery. Both these fragments were taken out. And final angio showed some haziness of the left renal artery, but still on check angio it was found to be normal. These are the 2 fragments caught up in the end snare. Successfully we could finish the procedure with so many stents and a full metal jacket in the RCA. Patient is now coming for follow-up. Unfortunately, she is asymptomatic. The lessons we learned that you always have a low threshold for guideline, and uncoiling of the stent while snaring out the fragment from the ostium should be kept in mind. And bioptome, the usual bioptome we get is less maneuverable, and OCT definitely has a place in stent failure. And we use a 3-loop end snare, coronary micro snare for successfully snaring it out. Thank you.
In good case with a lot of procedures. Initially, the problem started with you noticing the distal haziness.
Yes, sir.
So after that, you took give NTG and.
We gave NTG, but still that haziness was there.
So what was your impression at that time regarding the haziness?
We thought it was a distal dissection, but the imaging catheter was not going, so we thought of stenting it.
You are not sure whether it was a dissection or something?
We are not sure, but we had some haziness there.
But in the last injection also the same thing is persisting?
Yes, sir. In the OCT image, but that was didn't seem like a dissection. Just a small fibrous plug, but it was not a significant geographical miss also.
I don't know. Bioptome in the arterial side, I don't know how to use.
It was an excellent, that is, you snared the stent from the renal artery. I think it would have been a tough time for you. But one thing, I don't know why your imaging was not possible to confirm whether it was a dissection, stent fracture or something that.
It was a CTO, and we took some 1.5 to 2 hours for that procedure. So the imaging catheter the aux catheter was not going. We had some limitation of the finances, so we thought we'll send.
But now we have landed up with more financial burden. Okay. Anyways, it was an excellent case.
Anybody in the audience?
I mean, 5 or 6 hours probably, in multiple settings in the morning and evening.
Okay, thank you for the nice case.
We'll go to the next case, wire entrapment by Dr. Trudip Singh Saga.
Respected seniors and my dear friends. Thank you for Jagabal sir for giving me an opportunity. I am presenting a tale of an untamed wire. A 67-year-old female who had dyspnea on accession class 2, type 2 diabetes, hypertension, dyslipidemia, had good LV function. EMT was positive, so we took her for an angiogram. Angiogram was showing a minor plaque in the proximal LAD, and distal LAD was a small caliber vessel. RCA was showing some significant disease in the distal RCA extending to the PD ostium. And it was a mid RCA was a tortuous RCA, while proximal RCA was normal. PLV was free of disease. So on that basis, we planned for a PTCA to RCA, extended from the PDA till the complete distal RCA. So RCA was engaged with a 6 French EBU 3.5 catheter, PDA and PLB wired with a Sion blue wire, thinking about difficulty in crossing the lesion. And then we pre-dilated with a 2.5 and 15 mm compliant balloon, semi-compliant balloon, serially from PLV to the distal RCA, PDA to the distal RCA, and then 2.75 into 40 and science expedition was delivered at 12 atmospheres across the jail PLV wire, PLV. So this was the sequence of events that happened. After the dilatation of the stent, immediately we removed the PLV wire. We tried to remove the PLV wire, but the whole system came out. And then suddenly what happened is that we took an image, we saw that our tip of the wire was not that much smooth, so we took up the image and saw that the proximal portion of the wire was broken and entrapped within the PLV, extending till the proximal portion of the stent. So we thought that this may be the picture of the stent and the entrapped wire. So the broken wire, the proximal portion of the broken wire will be at the proximal portion of the stented part of the stent vessel, and the distal portion of the broken wire was found in the PLV. So the options were there in the sense of snaring it out, but it's not possible in this case because there was the proximal portion of the broken wire was not outside. The second option was to stent the PLV from the ostium of the PLV till the proximal portion. So that option was there in our mind, but how to be done with another 2 wires with a tortuous RCA? That was our question. Then we explained to the bystanders, and then we went ahead with recrossing with the new wire, with the BMW wire. And but at this juncture, we didn't wire the PDA. We went with this single wire and then serial balloon dilatation with 1.252 and 2.5 semi-compliant balloon after recrossing was done, and then stented the PLV with the 2.5 into 23 mm science expedition across the entrapped Sion blue wire in situ. So this was the events that happened. We recrossed, then serial balloon dilatation, following which we had stented the lesion. So this was the final picture. So PTCA was done to the RCA, PDA and PLV both with a entrapped Sion blue wire inside. Later, after 1 year, on dual antiplatelet therapy, patient was totally asymptomatic. Then we asked her to follow up with an angiogram itself. But because of that nightmare, neither the bystander nor the patient was allowing us to do so. So we went ahead for a CT coronary angiogram, and CT coronary angiogram did not show any residual wire inside, and there was a fully expanded and flowing vessel. So this was the initial picture and final picture after discharge after 1 year. So our take-home message is wire entrapment fractures are rare. Definitely entrapment is likely in angulated as in our case or in a calcified vessel. Early recognition and management prior to side branch wiring and fractures in bifurcation lesions is critical to prevent trapping or breaking wires. Surgical removal of the entrapped wire can be done, and stent placement and other retrieval methods like snare, etc. are although authentic, not that much authentic, but rarely such management protocols can be done. Thank you.
The proximal part of the wire came out fully,
sir.
Because usually sometimes what happens is uncoils and then creates a problem. So
it came out fully, sir.
It had come out fully.
Yes.
Now only thing is there is an additional wire and a stent inside. Maybe that would be better option, because trying to get it out will be more difficult.
Yes, sir.
Why do you thought of wiring the PLV, first of all? Because you are not planning for a
because
bifurcation
it was a
stenting.
tortuous vessel.
You are not planning for a bifurcation stenting.
No,
and your
not for a bifurcation.
PLV ostium appears open well.
It was open.
Chances of getting pinched will be very less, I think. Then
But
why do you thought of wiring the PLV?
Because we were trying to do a single stent procedure.
Okay.
And it should be a long stent mostly. And there was a tortuous mid RCA. So we tried to wire the with a 2-wire technique we planned for this procedure. So that's why we wired the PLV. So that will be little advantage if it's not pitched.
Because personally, I think it was like wire could have caused that. That is true, but I didn't find any.
It was actually N wire.
Anybody from the audience want to? We'll go the next.
We'll go to the next. By Dr. Gangan, Nightmare in Tortuous Left Main.
Good afternoon all. Thank you Jayagopal sir and the CSI team for allowing me to present this case. Dear teachers and colleagues, this is my case, a nightmare in a tortuous left main. My patient is a 63-year-old lady who had a effort angina with good LV, background history of hypertension. For these symptoms, she underwent PSIT ostial RCA in January 2022. At this point, she had only borderline left main disease. She was pain-free after the procedure and was doing well, but around 3 months back, she started having recurrence of symptoms. Despite maximal anti-anginals, there was no relief, and hence the decision was taken to do a repeat coronary angiogram. So checking the right stent, the stent is patent. There is mild degree of restenosis, and I left it alone. Coming to the left system, the disease you can see the left main and the LAD is almost like a spiral course. The disease in the left main is extending from the osteoproxial left main 80% and ostial LAD is around 70%. I used EBU3 guide despite being an osteoproxial left main because I needed good guide support. And I found that by manipulating the guide properly, I was able to avoid guide damping. This shows the lesion in multiple views. You can see the spiral nature of the lesion. Now at first attempt, carefully I wired with the Fielder FC. And after that, using N balloons, I was able to dilate the entire lesion, the 27512 balloon. And following it, I went on with stenting. I went upfront with a guide liner because I knew the difficulty of tracking a stent. I used a new guide liner. There was some difficulty with tracking it within the stent, within the guide. And finally, I was successfully able to track a 328 stent and correctly positioned it and then stented it. Following stenting, the stent appears reasonable fair. And next I went on with post-dilation. Now at post-dilation, I was not able to pass a single balloon despite using short New York balloons. None of the balloons was tracking. And while attempting, I found that the proximal stent was getting crumpled and getting pushed further distally. And eventually the entire system backed out, the guide, the wire, everything backed out. And I had to start from square one. I had re-engaged the guide, but while rewiring at this point, the wire was not passing exactly through the stent, but through the proximal stent studs. Multiple attempts were made with multiple new wires. However, I could not pass well within the stent. So at this point, I took the decision of opening up the stent studs proximally and then putting another stent across the lesion into the distal LAD stent. I used another 2.8 balloon to open up the stent. However, what I found that was the LM to LAD dissected, the flow began decreasing, patient started having pain and began to go in for hypotension and bradycardia. At this point, in rapid fashion, I used a 1 balloon, 1.5 and 2 balloon and opened the struts. And then again using the guideline, I used another trackable stent, a 3.520 stent. I pushed it across and distal stent, and since I would not have another option for post-dilation, I went up to 20 atmospheres. There was some thrombus across the stent distal in the LAD, possibly because of the extensive guide manipulation, etc. Intracoronary tirofiban was given. And following this, the final result looked good. Patient's BP improved, chest pain decreased, and this procedure was completed with close to 3 hours and a contrast of 310 ml. But post-procedure, she did well. There was no major issues, and we were able to discharge her unevenly on day 3. She came for follow-up twice. She's doing well. No major issues as of now. Now, some issues I thought the first option would definitely be an CABG, but patient is a frail old lady, and they were not very keen. Maybe 2 stents, putting one stent distally and then the another stent proximal would have been a better planned option. Better relation preparation may have been helpful, and using more trackable stents upfront might also be other options. Thank you.
Tortuous LM was the issue. Tortuous LM was the issue.
Yes, sir.
Were there any calcification?
Grossly, no, sir, but I think there must have been some degree
There must
of
have
minor
been calcification.
Yes, sir.
And the LCX also was small.
L6 was small.
Imaging was not done?
No, sir. This was done at a peripheral center with limited financial options.
I think calcification would have been there. That would have been made you
One issue,
tough
yes,
for
sir.
you to. Cutting balloon would have been, a lesion preparation would have been a better
option.
Thank you. We'll wind up the session.
Thank you very much, sir. With the kind attention of the delegates, we are just going to move up the quiz program. So the participants are requested to kindly come on to the front. May I please also invite the jury, Dr. Krishnamurthy, and the quiz masters, Dr. Abhilash and Dr. Arun Gopalakrishnan, please. The names of the participants coming up on the screen now. We request you to kindly come on to the front. There's a slight correction. The jury member, Dr. Krishnamurthy. Dr. Shivashankar. Yeah, Dr. Krishnamurthy is not here, right? Okay. Okay. Announce. Dr. Shivashankaran will be the jury member. We request the participants to kindly come forward, please, fast. Over to you, sir.
Dr. Manjunath from Kottayam Medical College.
Dr. Sri Gopal from Kottayam Medical College.
Dr. Srinath from General Hospital, Ernakulam.
Dr. Srinivas Dangar from General Hospital, Ernakulam.
Dr. Prem Shankar from MCH Trivandrum.
Dr. Niranjan, MCH Trivandrum.
Dr. Karthikeyan from Sri Chitra Trivandrum.
I'm Branda from Sri Chitra.
Am I audible now? Myself and Arun will be the on-field referees, and Shivashankar sir will be attending. Sir is the VAR, like video assisted review. Any dispute, any ambiguous questions, sir will be the authority. Okay, so we are going to start it. Let's see. We will have first two rounds are called tiki-taka rounds. You essentially know what is tiki-taka. Pass, again pass. This is popularized by the Spanish team. So what happened in World Cup is they went on passing and forgot to score. So the question will be directed to each team. If you pass, you don't get mark. The passed person gets the score. Okay, it's a regular passing round, but we will be calling it as tiki-taka. It will be initially team A to D. Then after the two initial tiki-taka rounds, later will be team D to A. Okay, no confusion. Direct question gets 10 marks. The passed question gets 5 marks. Okay. Then we have a free kick round. 6 kicks will be taken. Called a Messi round. You know, Messi is one of the best in free kicks, right? But intentionally, we have put it as Messi. Why? M-E-S-S-Y. Because this round can become Messi. Because this round carries negative marks. This will be a buzzer round. So you have a buzzer. All of you have buzzers, no? So 6 kicks will be directed to all. So whoever presses it first, they get to answer it. But if you give a wrong answer, that is the Messi part of it, you get -5. Okay, just remember that the Messi round has -1, negative point. Okay, it is open to everybody. It's a buzzer. Right? Third, we have the Mbappe round. You know who is Mbappe? He was the fastest footballer as per the FIFA ranking. So this round has to be fast. There is no negative marking here. Remember that negative marking only for Messi. Here, in 1 minute, you will be asked 4 questions. Each question carries same mark. Every question in the quiz has 10 marks each. If you answer 4 questions in 1 minute, you get 40 marks. There is no negative mark. Okay, so you have to rush fast. Each round we will explain. Okay, that is the Mbappe round. You know the Mbappe. Now, again, round 5 to 6. Until now, I will be managing it. And I think FIFA felt that I am getting older and I may not be able to play for 90 minutes. So I have a backup referee. He will be taking care of the cues from there. Tiki-taka round 5-6 will be done by Arun. It's the same, but the rotation will change. Now to negate the luck factor, we will negate it from D to A. Okay. 2 rounds will be there. Tiki-taka, again passing round. Then there is the free kick round again, which is also the Messi round. You have the buzzer, you have the negative point. And finally, if we have a tie, we have tiebreakers, there will be 2 kicks. Not 5 like football, we don't have that much time. So 2 kicks. Both kicks will be taken, being a tiebreaker. Okay. If still we don't have a winner, we will go with a sudden death, which will be a single kick. Clear? Okay, so let's go with the match. Again, audience questions are there. Sure. Audience prize is also there. It is there. It's guaranteed. So, again, simple. All direct questions will be 10 marks. Fast question, 5 marks. Messi round has wrong answer, -5. Direct answer, 10 marks. Okay. So, starting with tiki-taka. Okay. Starts from team A. Let's start. Okay. I don't have a whistle. Okay. So, identify the lesion and what is the underlying condition.
Splinter hemorrhages, infective endocarditis.
No. Team.
Jailway lesions.
No. Team C. Osler's nodes. So the answer, team, yeah. What is the underlying condition? Infective endocarditis. You are correct, but see, these are Janeway lesions. Okay. The other one was different. This is more violaceous patches. And these are the splinter hemorrhages. These 2 are already answered. So I think next question I will go to the audience. We have the prizes ready for audience. What is that? Proud spot. I think audience gets the prize. There is a prize. Audience has got the prize. Then to team B, identify the lesion and what is the underlying disorder.
Palmar xanthomas.
Palmar xanthoma, correct. Which is the underlying disease. So you get 5 marks. Palmar xanthoma actually, but you are getting the mark for it. What is the condition?
Type 4 hypercholesterolemia.
No. Team C. Which type? You have already told that, no? Mike.
Familial dyslipidemia type 3.
Type 3, correct. So you get 5 points and the team C also gets 5 points. So type 3, ApoE2 mediated, it's the Palmar xanthoma. Okay. Team C now. Direct question to team C. Identify the lesion and what is the underlying condition?
Subcutaneous nodules.
Yes. Which condition? Unless you tell the condition.
Acute rheumatic fever.
Correct. So you get full marks. It is a subcutaneous rheumatic fever. A subcutaneous nodules of acute rheumatic fever. The characteristic feature is the extensor aspects, isn't it? It's same. Okay. Audience. It is the, again, erythema marginatum. Who told that? Yeah, he gets a prize. Erythema marginatum. You have again ring, like, these are uncommon in Asian patients. The peripheral, it's non-itchy, not pruritic, and peripheral, some demarcation at the periphery, central clearance. Question direct to team D. Identify the lesion and what is the underlying condition. A patient is in a young hypertensive. Passes to team.
Takayasu.
No.
Crossing of arteriovenous. Crossing of arteriovenous.
No.
Salusi.
No. Question passes to.
Copper wiring.
Pardon?
Copper wiring.
Wiring. Okay. What is the condition?
Hypertensive retinopathy.
Team.
Silver wiring of vessels.
No. Audience. Coarctation. They are the core. Madam gets the prize. They are the corkscrew. The larger ones are the veins. The other ones are the arterioles. You can see corkscrew, like they are the corkscrew arterioles. And I gave a clue also. Young hypertensive. So it's a coarctation of aorta. The X-ray of the patient, coarctation of the aorta. Now again, tiki-taka round 2. Question goes directly to team A. A, B, C, D in that order. Describe the findings and what is the condition. Describe the condition.
Short PR interval, normal sinus rhythm.
You told short PR interval.
Short PR interval. Syndactyly.
Okay, syndactyly. What is the condition? What is the ECG finding?
Noonan. Webbed feet.
There is a long QT with syndactyly Timothy syndrome. Timothy.
Excellent. But they told syndactyly. Okay. Yes. Sir, we are giving only for the full answer. Okay. So you get, that's the answer. This is the Timothy syndrome. Prolonged QT, syndactyly, they can have AV, like conduction issue due to prolonged QT, can have prolonged polymorphic VT in addition. Team B. Identify the lesion and what is the underlying condition.
Erythema nodo.
No. Question passes to team C.
Target lesions. Target lesions.
You have to be specific. Target lesion is a big differential diagnosis. Question passes to team D. You have a clue in the first. No, I'm not telling any clues.
Erythema migrans.
Erythema migrans chronica.
Seen in Lyme's disease.
Correct. 5 marks to team D. Erythema chronicum migrans and Lyme's disease. Questions goes to team C. Identify the anomaly. What is the underlying condition? There are a few phenotypic features. And what is the underlying, say, at least cardiac condition?
Congenital rubella syndrome?
No. Question goes to team D.
Short philtrum with warfare in.
No. Question comes to team A.
Malocclusion of tooth, Ellis Van Creveld syndrome.
Correct.
ASD, common atrium.
Very good. Well, ASD, common atrium. ASD, and you can see polydactyly. How many fingers are there? This absent teeth, lady actually had. You can see absent teeth in the lower lip. The conical incisors up. Common atrium is. Now goes to the team D. Team D. What is the condition? And name the most common scoring system to assess response to treatment.
There is glossitis, vitamin B12. There is a glossitis with cheilitis, strawberry tongue.
What is the scoring system? Answer is correct.
Vitamin B12 deficiency.
Oh, okay.
Strawberry tongue, Kawasaki disease.
What is the scoring?
Scoring.
Pass.
Pass.
Pass. Pass. Audience.
What is the most common scoring? Audience responds to what?
IVIG.
Now complete the score.
Called the Kobayashi score. These are the components. They told Kawasaki. Team, so you get 5 marks. Get 5.
That was a pass question.
Pass question.
2.5.
Okay. 2.5. Oh, half of the half. Correct. Fine. So let's know the score. At the end of the tiki-taka rounds. Now, we'll go to the next round. Okay. We know this will be the messy round. Okay. So all of you ready with your buzzers? Yeah.
John, may you please press?
Working? Team C. So let's 1 minute. Let's reset and then do. Yep. So if you get correct, you get 10 marks. If you get it wrong, you get -5. Okay? Identify the image and interpret.
A hematoma, intramural hematoma.
No, you get -5. You can see that, you can see the shadow extending beyond. It's well demarcated. So it's
Question passes to the audience.
here there is no pass between the teams, so it directly goes to the audience. Direct. It's calcium. It's essentially calcium, and you can see. Yeah, all. Okay. They can get the prize. Okay. So, what is the difference here? This is also again the same lesion, but you can see that it extends almost 180 degree, isn't it? And so it is more significant. May not be. You may require some other ectomy treatment for it. Okay, both are calcium only, but one is an calcific nodule. The other one is a circumferential calcium. Well demarcated, and you can see beyond. Second question, ready with the buzzers?
Hold on.
Yeah, we have reset it. So, all 6 images are MRI images. The T1 weighted image, T1 weighted. This is healthy, this is hypertrophic cardiomyopathy, this is AL amyloid, this is TTR amyloid. What are these two? Healthy one is green, that is the green. This is the color grading. This one is hypertrophied but healthy, green. This is much hypertrophied with less red here. This has more red, so that means red means scar. More hypertrophy, less scar. Less hypertrophy, more scar. That is AL and TTR. What are these two? The importance is these are diagnostic. That is why we do MRI. Yeah. If you don't answer, at least you can tell one.
Know the question. Yes, select. Either C or D, but you will have to tell which you are interpreting. Choose of either C or D, but you have to get wrong answer. That's also a problem. One of them will be thought. Audience is already raised their hands.
Audience? Yes, ma'am. The color coding, this is the normal, green. This intensity, T1 intensity is lower than normal. That is the crux. What is that? One is Fabry's, the other one is iron overload. For these two conditions, the MRI is very simple to diagnose them. The low intensity T1 signals. Okay.
One is Fabry, other one is?
Iron overload. Iron overload.
Nice learning.
Iron overload. Iron overload, you can see it is extensively blue, very low T1 intensity. Where it is, this one is interspaced with the normal, the space with the normal. And there is significant hypertrophy. Iron overload may not have that hypertrophy as much of Fabry. Fabry's is basically because of you have some fat, which may show low T1 intensity. We'll go to the third question. Ready, no? Describe the ECG and identify the structural anomaly. This is the third free kick in the round. Nobody is attempting? Oh, BHAS. Yeah.
Inverse propagation of R wave in V1 to V6.
Yes.
Probably dextrocardia.
Yes. And what's more? One more. Yeah. We'll give you mark. But you tell one more. Quantify one more. What is the peculiarity of dextrocardia? but it's a site test. Okay, but I think we promised to give full mark.
Okay.
We'll get,
No, because citus was very, very important. In the,
okay, then should we give
half
full
the
or
mark.
half mark?
Half the mark.
Half mark. Jury, sir is the final word. So we'll give you, because you need to start interpreting from there.
So today morning also X-ray ECG was shown. When you interpret dextrocard, it's very easy to say whether it is citus, altus or inversus.
Yeah.
That is extremely important in interpreting dextrocard.
In fact, the ECG has to be interpreted from P wave, situs. So situs, solitus, dextrocardia. You get 5 marks for dextrocardia.
Sorry, I am reducing the 5 marks.
No, sir.
I think
we
that is
agree
very important lesson for you to keep in mind.
Yes. Yeah, but sir. We'll go to the next question. Next kick. Identify, describe the ECG. Nobody pressed? So you have pressed. Ah, okay. Then explain. Yeah.
There's a wide complex tachycardia.
Go on.
Wide complex tachycardia with a retrograde P after the QRS complex.
Okay.
So probably with a retrograde 1:1.
Not 1:1. Go ahead. Maybe 2:1 or even dissociation.
1:1.
Yeah. What else?
With RBB morphology.
RBB morphology.
And,
yeah.
and a left axis deviation.
Okay. Where is it coming from?
It's coming from probably a fascicular VT.
So which fascicular?
Left posterior fascicular VT.
Correct. It's a left posterior fascicular VT. I think we'll give you 10 marks. You can see RBB tachycardia, differential diagnosis. One of it is, you have different differential diagnosis, but for a time we are not discussing that. You can see, in fact, a fusion beat there. You have VA dissociated or 2:1 VA conduction, 2:3 AVF negative. It's a posterior fascicular VT.
Is the fusion beat?
Resetting, and we are going to the 5th kick. Identify the ECG. Brave ones gets the point. Yes, Sir. 2 brave losers. Team D. Team D. Yeah.
ECG, it's there is intermittent pre-excitation, like sinus rhythm with intermittent pre-excitation, with that delta wave is positive in P1 to P6, and
Okay,
like
so where is the, so you are telling it as intermittent pre-excitation. Agree. So where is the pathway?
Left anterior.
Okay, left-sided pathway.
Left-sided anterior and.
I think left-sided pathway is fair enough. 2-3 AVF is posterior, so it's not posterior. Could be left lateral or left anterior.
Is negative.
Okay, we want to be. I think they get the mark. It's a left intermittent pre-excitation. So intermittent means the pathway refractory period can be longer. So may not result in an arrhythmia. So intermittent pre-excitation, left lateral pathway. Get the marks. So going with the 6th kick. This is the final kick of this round. Identify the image and describe. Yeah. Team D.
it's a IVS showing like, showing stented segment. It is a stented segment.
Okay.
With underexpansion with a neo-intimal hyper. No. With underexpansion.
Okay, I agree with that. An intravascular image of a stent which is underexpanded because this is the original lumen area and you have some amount of malocclusion here. They will get the 10 marks for it. 10. Okay. So that's the end of round, 3 kick round. Let's know the score now. Team A, 1.5 marks. Team B, 25 marks. Team C, 15 marks. And Team D, 25 marks. Go to the next round. This is going to be the Mbappe round, where we need a timer. 60-second timer. You will have 4 questions. Each two, I will be starting with the team A. Okay. You have the option to say pass. So we'll go to the next question. Or answer and go to the next question.
Can we come back? Can we come back to the question after passing?
If you have enough time. Say if you finish all the 4 questions in 40 seconds, you have 20 more seconds. So you can actually come back. Total 1 minute will be there for all the 4 questions. You will have 1 minute. So even if you go to team the 4th question, you can always come back to question number 1. That's not an issue.
So Team D, I think you should switch off the...
Timer ready? Can you check?
Team D has kept the buzzer on. Just switch that. Yeah, thank you.
Can we check the timer? Yeah, just start place. So it's playing there. Can you show it here? Oh, it's here. Oh, okay. I can see. You can also see the timer there. Can you see the timer there? Yeah. Correct. Okay. The team A key, you can look at there, the timer. Please reset the timer. One minute for question. For key. Going to the first question.
The timer is not set.
Can move laptop, but okay. Timer reset. Yeah. Starting.
The timer.
Okay.
First question. Name the landmark trial series this famous gentleman is known for. What is, you want to answer?
Pass, sir.
Pass. What is the mechanism of action of the sototercept?
For pH.
What did you tell?
For pH, sir.
For pH. Correct.
We'll come back to it next.
Yeah. Next. Identify the condition.
TAPVC.
TAPVC, correct. Calculate the shunt fraction for an adult with a TAPVC. Aortic saturation 80% and mixed venous saturation 60%.
Yes.
You want to come?
75.
You want to answer that? There is no negative mark in this round.
75.
75. No. You want to
First 10
answer
seconds.
First question?
Framingham. Next.
Next question.
Second. Eugene Brown.
That's the second question, which you told us pH. Half mark. We'll see the answers. And at the end, we will decide how much the mark. Eugene Brownwald is there, but that was not the question. Timmy is the trial, Timmy series. Okay. So you did not get mark for that. Okay. Sototercept is essentially activin 2 receptor or TGF beta. And yeah, sir presented it yesterday. So but he told it is. Yeah, but he told pH. I think. Okay, but he told pH. I think we should give, sir, is it okay to give 5 marks? 5 marks. He told 5 marks. So we'll be giving you 5 marks. Then the third question you told, TAPVC gets 10 marks. TAPVC, it's no. And how to calculate the shunt fraction? Iota minus mixed, PV minus PA. Here iota and PA are same. Mixed variance was given 6. PV is 100. There is no shunt up, 1 to 1. Okay. So that you did not get a mark. You get 15 points this round. Okay. For you also this is going to be like repeated. Okay. I'll have buffer slides. So team B ready. We'll reset the time. And reset. You tell us when you done. Starting now. Who did the first coronary artery stenting?
Grand sick. Grand sick.
Grand sick. We'll go. You want to go to the next question?
Next question.
You can always come back if there is an issue. What is the mechanism of action of the drug Baxdrostat?
Pass, sir.
Pass. Identify the X-ray.
Pass.
What is the required stent size at this level by Finnett's law? It is 2.5 distal and 3.5. What is your proximal size of the vessel? Recommended size?
3.
There is no negative mark. So you want to see the question or want to come back? Time is up. We'll describe each question. Who did the first coronary stenting? Who? PVL. Yes. Sir gets the prize. Sigbert and Puel. Sir gets the prize. This was the publication there in New England Journal. What is the mechanism of action of the drug Baxdrostat?
The audience should answer. I'm going.
Aldosterone. Gets the prize there. Selective inhibition of aldosterone synthase in resistant hypertension. Used in resistant hypertension. This was tricuspid atresia with juxtaposed atrial appendage. Yeah. Differential diagnosis. Differential diagnosis. And Finnett's law, you know, it is 4 millimeter. 3.5 plus 2.5, 2/3 of that. You told 3, no? So you get no marks. You couldn't answer 4. That's what. You did not, right? Okay. So going to team C, timer. Set. Yeah. Identify this person. Team C.
Next.
You told pass.
I mean pass. This is
Yeah.
pass.
What is the mechanism of action of asundexian?
Factor 10 antagonist.
Pardon?
Factor 10 antagonist.
Factor 10 antagonist. You want to answer next question or?
Next question. Pass.
Identify the X-ray. Yeah.
PGA.
Correct. RA mean 5. PA pressure 45-20, mean 30. Wedge 10. Cardiac output 5. Calculate total pulmonary resistance. Time is up. No, 1 minute. Time is done. Only Mbappe's can. So, identify the person. Eisenmenger. This is the Eisenmenger. Asundexian, I think it's a new molecule. No, it told factor 10. It is 11. Factor 10 is close, but not correct. In your oral factor, area correct, yeah. Yes, sir, does he require 5 marks? 5. Sir, giving 5 marks to them. 5, because they identified it as an anticoagulant. 5 marks to team C. And this is a textbook X-ray gone side with increased pulmonary blood flow. Yeah. And even though many numbers were there, you have to look at. You don't have to look at all the numbers. In fact, mean pulmonary artery pressure and cardiac output. That is 30 by 5 is 6 total. Yeah. Should be at the tips, like you don't have to look at all the numbers. If you know it, it's 30 by 5, 6. The other one is 30 minus 10 by 5, 4. Pulmonary vascular resistance is 4. Total pulmonary resistance. Okay. Team D, ready? Should we reset or something? Ready. Timing starts now. Identify the gentleman or their contribution to cardiology.
First, pacemaker.
You want to next question?
Next.
What is the mechanism of action of the drug tafamidis?
ATTR inhibitor.
Okay, we'll come to the discussion. You want to see the next question?
Next question.
Identify the X-ray.
Cardiomegaly with PH. AST Eisenmenger.
Correct. That's correct. What is the oxygen carrying capacity of arterial blood with 10 gram per deciliter at room air?
10 into 1.36 plus 13.6.
Yeah, you
13.6. 13.6 into 10 into
time is up, we will discuss.
ml.
Fine, it's fine. We'll discuss. Anyway, you attempted the question. I think we'll be fair to all the teams. Hertz and Edler. Echo. You could see the Siemens label there. Echo. And this is the first publication where they showed the M mode. A mode and first M mode. That you did not answer. Tafamidis, you told transthyretin. You stood in transthyretin mediated. Amyloid. I think we'll give 10 marks. Then ASD with PH or even idiopathic PH because you don't have much end-on view. So idiopathic PH is another DD. So you get 10 marks for that. The calculation is, this is what you are telling. We asked to ignore this 0.003, but you are telling this hemoglobin into 1.3, correct? So 10, they did not tell the units. So, sir, what is the...
Half the door, because that they should be very clear, especially from...
So we'll give half marks. So 5 points for you. Because the question also tell the units. Okay. So that is the end of Mbappe round. Now we are calculating it. Meanwhile, the scorecard is being calculated. We have a question to the audience. Who was the fastest player in World Cup 2022? We told it was we have our rounds named as Mbappe. Then there is no fun now if he is the same person. The question is about. It was not Mbappe. Mbappe is the FIFA's fastest footballer. But in this World Cup, there is one person who was faster than. He's He's not a European, he's not an American, he's not a South.
Morocco?
It was Kamaldeen Suleimana of Ghana. He recorded 35.7 kilometers per hour. That was the fastest in our World Cup, last World Cup. Okay. So, scorecard?
A 20.5, B 30,
So we are going to the second half of this. Okay.
now the rounds swap from D to A. Question to team D, identify the device or devices.
This CRT along with that LV that for heart failure.
Cardiac contractility.
You have to tell one answer. Because answer.
TD and there is a extra thoracic also we have contractily modulator, cardiac contractily modulator.
Question passes to team C.
CRT and subcutaneous ICD.
Question to team B.
Cardiac contractility modulator.
Team A. Audience.
CRT with leadless pacemaker.
Audience.
F20.
Audience. Anybody in the audience? This is the Wise CRT. Wise CRT, where there is a lead, additional lead in the left ventricle, endocardial lead. So, identify the device.
No negative mark. Daga can always pass.
Mitra clip.
No. Team D.
Coronary
You have
sinus.
the image on the right side.
Coronary sinus.
Go to the team A.
Pulmonary endarterectomy. Embolism.
Team D.
Coronary sinus reducer for refractory angina.
No. Audience. No. It's not coronary sinus flow regulator. You have the steps given on that left side. You see that? How the coronary sinus angiogram being done? Something is piercing into LA. And then you have a device into LA to CS. LA to CS shunt. For very high LA pressures, diastolic dysfunction, people are trying now to decompress the LA. Edwards Life Sciences. This is LA to CS shunt.
The trial was published just last month. Now, question to team B. Identify the device, or you can give the indication. Team A. Team D.
Transcatheter valve. Blunt.
Valve. Team C. Okay, now no marks. You can at least describe what all components you are seeing in this. You
There
tell
is
a
a
valve is a
battery.
what are the components that are seen?
The battery,
There is a PG.
some balloon can regulate the flow.
Something similar to our IAB. Need a balloon is the PA. Diastole, it fills up. During systole, it deflates. Somewhat similar to our IABP process. Gauge.
This is FDA approved.
It advances as code.
Okay, question to team A. Identify the device.
So the mitral valve, tendine valve.
Excellent.
From above, where it actually plays transapically. So you get 10 marks for that.
So that is the transapically deployed transcatheter mitral valve. So now we go back again to team D for the next round. Ready? Identify the abnormality.
Left mitral leaflet with MR.
Very good.
Different types of mitral valve. Identify the abnormality. Team
Question to team C.
MR, there is a split in the PML, AML, sorry. Left AML.
Question passes to team B.
There's a MR with a restricted opening.
Team A.
Parachute mitral valve.
Team D.
Perforation.
What is the prime? First thing is, now, yeah, audience, very evident. It is not mitral regurgitation in the first place. This is mitral stenosis. Surprised that everybody is telling it's mitral regurgitation. It is stenosis, supramitral membrane. Okay. The aortic valve is not profiled. Now, question to team B. Identify the abnormality.
Dissection.
You told. Can you be louder?
Dissection of.
Pass. Question to team A.
Double inlet mitral valve.
Double?
Double inlet.
Very
mitral
good.
valve.
It's a double orifice mitral valve.
Mitral.
Team A. Team A gets 10 marks. 5 marks.
So, direct question to team A. Identify the abnormality.
Rheumatic heart disease. There's Epstein. RARV seems dilated. There's an offset sign, a displacement. Epstein.
Question to team D.
Single papillary muscle parachute mitral valve.
Team C.
Parachute mitral valve.
Team B. Audience. Very good. It's a mitral arcade or a hammock mitral valve. What is it? Can you describe the abnormality? Very good. It is direct attachment of the leaflets to the papillary muscle. There are no chordae. Direct attachment of the leaflets to the papillary muscle. That is called hammock mitral valve. What is a hammock, by the way? Might see somewhere around this resort also. It's called a hammock. Okay, a hammock mitral valve or a mitral arcade.
Kottayam Medical College, 37.5 points. Team B, Ernakulam Medical College, 25 marks. Team C, Medical College, Thiruvananthapuram, 30 marks. And Team D, 60 marks. Srijitra.
So sir said it's time to be messy now. You need to catch up. So everybody ready with your buzzers? So identify the valvular lesion. Team B has selected
Mitral regurgitation.
-5. Now, does anyone in the audience want to take without marks? Why? Even when the aortic valve is closed, you can see the regurgitation. When the aortic valve is closed, the ventricle is filling. So that is aortic regurgitation. This is chronic severe aortic regurgitation.
Go to the next. What is this mechanism called? Take your time. But to attempt, get 10 marks. Gets it -5. Previous question, who answered? D. -5. Take your time, but come with an answer. One of the things we learn in first MBBS day. Ganon, Gaitan.
Team D. Team D has.
The Bainbridge.
Louder.
Bainbridge reflex.
Very good. That is called Bainbridge reflex.
Atrial reflex, an increase in heart rate due to an increase in central venous pressure. Just come back to the table. See, there is absolutely nothing about other things. But whereas the RA pressure has gone up, heart rate has gone up from 65 to 90. When fluid, of course, when after 1 liter of normal saline.
So identify the devices. Now, since there are 2, you have to answer both. Otherwise, you deprive the other teams of the opportunity. Team B.
Subcuticular ICD.
And? So we may have a problem.
Pacemaker.
Now the question doesn't pass here, but maybe if the others want to answer, you want to answer, you will not get marks.
Leadless pacemaker.
So it is a leadless pacemaker with a subcutaneous IC. 0. So describe the angiogram. Team C.
Bicuspid aortic valve, Persian helmet sign.
Bicuspid aortic bandwidth.
Persian helmet sign.
Helmet sign. Wrong answer, -5. Now, the question doesn't pass, so the other teams will not get any mark. But does any of the other teams want to attempt? At least the findings. Audience.
Sir, status for CABG. Status for CABG.
There are 2 outflow tracks. Can you see there are 2 semilunar valves? There are 2 semilunar valves filling from one root injection. So when you have 2 semilunar valves arising from one root injection, what is the condition?
Trungus. Trungus.
Trungus has one root and multiple exits, not 2 roots. You have 2 roots, 2 valves and only one exit. Cannot happen in nature by default, no? It's a post-operative. This is called a post-AMS K stencil DKS surgery for hypoplastic left heart syndrome, or there you have end to side anastomosis of the aorta to the pulmonary artery, and the pulmonary artery is made as the is connected to the arch, and that is how the outflow tract is created. So when you see 2 roots and only one artery, the artery is the aorta, it's a post-AMS K stencil procedure. Okay, and you should have noted that there was sternal clips also in the previous angiogram, post-operative. Post-DKS. So -5 to team C.
Identify the abnormal.
The classical condition. Any of the audience, there are multiple hands lifted up. The answer is Olds anomaly. Olds anomaly, you see the absence of any myocardium in the right ventricle. You see only very, very hyperechoic, there is no myocardium there. And you have pericardial effusion also all around. The patient is in right heart failure. So last, identify this molecule. You've come to cardiology without passing biochemistry. You cannot live without this.
Aspirin.
You did not say, click your buzzer. You should have. And still give them the mask. Still give them the mask.
Sorry. It's aspirin. Aspirin. The team B gets 10 marks. Let's know the score now.
The final scores now.
D, Vijitra is 70 and they are the winners. Team A, Kottayam, with 37.5, they get the second prize. Team B, Ernakulam gets 30 points. And Team C, Medical College Thiruvananthapuram gets 25 points. Okay, so they are the winners, but game is not over. We actually prepared tiebreakers and sudden deaths also. So yeah, you can participate also, just for fun. The match is over, just doing the tiebreaker and sudden death. Okay, everything was fun only.
Dr. Abhilash and Arun has done a good job, and the usual stress of a quiz session was not there. That was also good.
50 slide. We are planning a tiebreaker. If we had a tie, because we don't have a tie, we are planning to take penalty kicks. And 3 months old girl, what is the diagnosis? Versus, it's free hit, no marks, but please, let's continue the fun. 2 questions in tiebreaker. It's an exam ECG. You give the differential diagnosis.
Clue number 1, cyanotic. Yeah,
Tricuspid atresia with
fine, acceptable. Why did you tell tricuspid? Yeah, why did you tell tricuspid atresia?
counterclockwise loop with LV dominance.
Isorhythmic AV dissociation. Marching of the P waves through the QRS. Isorhythmic AV dissociation.
What you told is correct. There is some
SA nodal. Bradycardia is there.
In other words, there is no AV nodal disease.
We'll have a time. With SC question. Person? That's not the question anyway. It's Van Damme. And this is the question. Sudden death question plan.
The clues are already marked. You can, if you.
When give back.
There is.
Do you want to attempt the
Yeah.
What is the diagnosis? Conduction.
Intra.
Not common. Age or HP. given us a clue, ma'am. And finally, we have the winners. They can come and collect the prizes. Yeah. The winner gets the. You remove it. The cup was there already.
Thank you. I think we would like to thank the Quizmasters for a wonderful session, Dr. Abhilash and Dr. Arun, and also the jury. So may I now request Dr. Shiva Shankaran to hand over the prize, the first prize to Chitra? Is that the Chitra team?
Sri Chitra.
Yeah.
Sri Chitra gets the first.
Please come over. And the cash prize of.
They have the cup at the background.
And the cash prize of 50,000 rupees. Sorry? Hello. And the second prize goes to Kottayam Medical College. I think Kottayam has really been in the limelight. And a cash prize of rupees 10,000. And finally, the third prize to General Hospital Kochi, cash prize of 5,000. Congratulations to all the winners and all the participants. I think that is a tremendous show. Thank you.
I want to ask a doubt. See, always we give one check, no? Why not we give two checks with the amount divided? Otherwise, it's difficult for them to share the money.
We'll consider that as a presidential order. We'll.
See, we give one check to two people. That's awkward for them, no? Hereafter, we should give
two checks.
Two checks divided.
Point well
anyway,
taken.
They deserve it. Congratulations.
Point well taken. So I think before we wind up with the valedictory function, we have one more session. I'm so sorry for having put that towards it because I think there are a few postgraduate students who wanted to leave. So the final session, kindly announce, please.
Yes, may I please invite Dr. Gopakumar and Dr. Hari Krishnan. Dr. Jayaprakash, if you're here, sir. Dr. Sujit Kumar. Presenter, Dr. Sheikh Shahid.
Sheikh Shahid. Dr. Hari Krishnan and Dr. Gopakumar, please throw the dais, please. Dr. Gopakumar. Sorry, last. Thank you. Please come over, Dr. Gopakumar.
Professor Manjuran will be co-chairing the session.
We are into the postponed last session, free paper session to non-award session. It's a non-award session. And there are three papers where all the three presenters are here. Sheikh Shahid. Only one. Who is present here? Sheikh Shahid. Okay, right, yes. Sheikh Shahid is going to present on dietary and non-dietary factors associated with the myocardial infarction in the young. Please.
Good afternoon, respected chairperson, faculty, seniors and dear colleagues. Today I am going to the paper, dietary and non-dietary factors associated with myocardial infarction in young. Introduction. Young people with premature coronary artery disease have a high rate of association of modifiable cardiovascular risk factors, and it is fast evolving disease with a high rate of mortality and morbidity. Beneficial role of dietary factor in prevention of chronic diseases and especially cardiovascular disease cancer has long been appreciated. Elevated blood pressure, glucose, lipid, as well as smoking, obesity, sedentary lifestyle are conventional risk factors. Several inflammation and coagulation markers like CRP, interleukin 6, fibrinogen are now considered as newer risk factor for young MI. Aim of study to assess dietary and non-dietary factors associated with myocardial infarction in the young, to identify the risk of association of CRP and homocysteine level with myocardial infarction in young. Methods: cross-sectional study population, 100 consecutive patients presented with myocardial infarction in Department of Cardiology, Government Medical College, Kottayam. Duration of study were 12 months. Inclusion criteria: age between 18 to 40, all patients fulfilling the fourth universal definition of myocardial infarction. Exclusion criteria: prior history of myocardial infarction, congenital heart disease, valvular heart disease, cardiomyopathy, and connective tissue disorder. Dietary habit assessment is done by using semi-quantitative reproducible food frequency questionnaire developed for study that evaluate the consumption of 13 major food factors, food items. 5 classes of response achieved: never, rare, 1 to 3 per week, 3 to 5 times per week, and daily intake of a particular food item. Scoring was given by 1 to 5 when the level of consumption was closer to dietary recommendation. 5 to 1 given when the consumption was away from recommendation. Follow-up done up to the discharge and at the 1 month after discharge. Coming to result, baseline characteristics of patient. Minimum age was 18, maximum age was 40, the mean age 32.6. Out of 100, 96 patients were male. In risk factors, most common risk factor was smoking, 53%. Consumption of frequency of various food of MI patient. In that, in carbohydrates, rice-based diet was in 80%, with root and tubers intake was in 80%, with low intake of fruits 17%. In protein and fats, red meat and product was 74%. And intake of full fat and coconut oil was higher side, 72 and 88 respectively. A dietary score of imported dietary score among the young MI patient. Total mean dietary score was 35, and dietary fiber score was on lower side, 11.4. In saturated fat intake was also 6.5, indicating bad dietary habit in young patient. Comparison of dietary score of MI with or without risk factor. In that, patient with low dietary score with diabetes, dyslipidemia, and obesity were significant p-value. Coming to newer factor, in that CRP elevation was present in 91 patients and homocysteine elevation were present in 37 patients. Outcome at 30 days of follow-up. No event in 90 patients, recurrent angina in 5, recurrent MI in 1, hospitalization was in 2, no death, 0 patients. Coming to discussion, high intake of root and tubers and low intake of fruits and vegetables were strong risk factor in our patient. High intake of full fat, coconut oil, red meat were strong risk factor in our patient. In our study, 60 to 65% of patients had low dietary score, indicating unhealthy dietary habit, strongest risk factor in development of MI under the age of 40. Prevalence of smoking where 53 was significantly higher in patients with CAD in young population. Tobacco smoking is one of the most powerful modifiable risk factor for development of CAD in all age group. Prevalence of dyslipidemia were 26. Out of 13 patients had high triglyceride level, and 8 patients had low LDL level, and 5 patients had high level of LDL level cholesterol. Family history is the strongest significant predictor of significant CAD. Only 8 in our study, only 8% patient had a family history positive, which is not statistically significant in our study. Obesity prevalence was 15% in our patient. Our study confirmed the previous observation study that suggests hypertension and diabetes are most common in old population as compared to the young patient. CRP violation was present in 91 patients, suggests acute myocardial injury. CRP value was more in anterior wall MI as compared to inferior wall MI, indicating LV dysfunction. Serum homocysteine level was elevated in 37 patients, which is one of the significant risk factor for MI. Conclusion: Unhealthy dietary habits were most common risk factor in young adult. Smoking was second most risk factor for development of in young. Novel risk factor like CRP elevation in acute myocardial injury and correlate with LV dysfunction. Serum homocysteine level are elevated in one of the risk factor in our young patient. Limitation: single center study, small sample size. We assess only two novel risk factors: ERP and homocysteine. Fallacies in assessment of dietary factor in some of patient. Follow-up was done up to 1 month only. Thank you.
Good work. In these patients, did you look at the in the dietary habits? Did you look at fast food intake? Fast food.
Fast food, actually, that we are not.
That's how. See, in young population, that's the most important thing they consume in large quantities, and you should have looked at that also.
Yes, sir.
What about homocysteine? What is the homocysteine? What is the reason in these patients? Is it some deficiency? Why did they have this elevated homocysteine?
We have we have not only values we have assessed. It can be congenital absence of enzymes.
So many people having congenital homocysteine.
Or maybe because of vitamin B12 deficiency, which is leading to elevation of homocysteine level. We have only assessed the value of homocysteine in 100 patients.
So what is your recommendation to these people regarding the diet?
Regarding diet for our patient.
Yeah. Did you give a special instruction regarding the diet to your patients when they got discharged?
About dietary, we have, yes sir, we have given.
The excellent thing here is that the most important point that was earlier discussed regarding smoking. Young people, it should be again reiterated that the smoking is one of the most important and modifiable risk factor. The one surprising finding is family history part was not significant, but the age group is around 30. The mean age was around 30. Perhaps if the population is around 40, mean age around 40 might 40 or 40 to 50, the family history would have contributed more. That's what I think. And there is efficiency in the collection of data regarding the diet. I think that, as Sir has told, the dietary habits of the South Indian population, especially Kerala, has changed drastically in the last 5 to 10 years. And most of them are taking all these fast food things that like.
People see the sweetened beverages have been shown to be a very high risk factor for coronary disease, especially regarding diet. So you consume drinking Coca-Cola or these type of sweetened drink also must be part of the history taking. So that also is important. Fast food, sweetened beverages, all these are extremely important. Okay.
Maybe sir, polished rice because the vitamin deficiencies which are.
Yeah,
that's one of the things which is the staple diet is rice. I think
that may be another reason.
Yeah.
They may be using a lot
Maybe
of polished rice.
Yeah,
so there can be vitamin B.
Hyperhomocystinemia and things like the vitamin
Yes.
deficiencies.
In this study because it's a very new study because he has gone into the diet pattern because he has come to the standard level to look at the diet level and it's surprising that LDL as a risk factor is very low. Am I right?
Yes, sir. Out of
100
dyslipidemia, 26 patients were there.
How the only 7 had a high LDL.
LDL was low in as compared to
LDL was high in 7.
Yes, sir.
That's a very so that means you have to look at what is the reason for atherosclerosis in young people. You have to go beyond this lipid theory. Okay, fine. It's a good approach. My
But
suggestion
Sudhir,
is
you may remember that when we had looked at patients with young infarcts, the most important risk factor we found was smoking.
Okay.
Very high, almost
Very high.
95%.
That was 90 at that time.
It was
now
95%.
still 53, probably the patient population which you are getting is different from other. It may not be the representative sample because even in young, the smoking has come down significantly. I think we can take 1 or 2 minutes. There may not be time factor because We are relaxed. We don't pressure.
No, I think
My
Sudhema, you have to leave also.
Yes, sir. But I have to appreciate because better. Because during my first IMA presentation, I had 2 people. So we have 2 audience. So basically, my suggestion is, why don't you apply this diet protocol in your residence of Kottayam Medical College and see what is the diet? No, as a paper diet pattern as per this thing. You have put some scoring system and present it.
That scoring was used in other studies also.
Not studies, in your residence of Kottayam Medical College.
Yes, sir.
It's a large number, young people. Why don't you study that?
But they are not having myocardial infarction.
It's not that. Don't wait for that.
You want to study the pattern.
Pattern and say that preventive measures.
But he is looking at patients with myocardial infarction. What is their diet that they are consuming?
So he is telling that his study is the major risk factor which he has seen in the young people. It's start smoking. Students are not smoking. But he is stressing that the diet pattern is the strongest thing. That is what he said. Okay.
There are many other factors like
Yes, sir, I am
stress
just
and
putting it in a different way.
lot of things.
I am putting it in a different way. That is, why don't you try to assess the diet pattern of the JRs, the residents, so that we get an idea what is the pattern and tell that in my study, this diet pattern was a risk factor, so why don't you change that? Okay.
Thank you, Sudhema. Thank you.
Thank you, sir.
Thank you.
Are
for
there
good
any more
presentation.
papers? Yeah, I think there's one more, sir. I think. Buddy?
Can you cut short to 5 minutes? I think we have to leave also.
Make a very quick presentation.
Quick.
Thank you, sir.
What is your name? Somebody. Beefy story.
Myself from Trivandrum Medical, I would like to brief history of this beefy story. A 14-year-old gentleman who is an occasional smoker and alcoholic with no previous comorbidities, who after consumption of beef at about 4 p.m. on 4/4/2023 had developed generalized itching and erythema by about 6 p.m. and he was taken to a nearby hospital and was given some anti-allergic medications. By 6:30, he felt some heaviness of head just associated with some autonomic symptoms, and an ECG was taken, and the ECG was suggestive of ACS, and he was referred to MCH Kottayam, MCH Trivandrum. At the time of admission, clinical examination, the patient was conscious oriented, the pulse and the vitals were stable, JVP was not elevated, S1, S2 was normal, no S3, S4, just respiratory system and other system within normal limits. So see, presenting ECG, it was showing ST elevation in inferior and anterior leads. We were suspecting an middle-lady lesion. So we have taken the patient for coronary angiogram on the same day itself. And this was a video showing the coronary angiogram. We can see a grade 3 thrombus in the proximal LAD with almost TIMI2 flow. And on the right injection showed the proximal RCA with some grade 2 thrombus, but the flow was TIMI, it was not compromised. The angiogram interpretation was it was non-obstructive coronary artery disease with a grade 3 thrombus in proximal LAD and a grade 1 thrombus in proximal RCA. So we have to, we had interest to look after the cause. The investigation were as follows: TOP-T was 80, followed by 1105. CKMB was initially 62, followed by 96 and 122. Other parameters were the normal list. Total count was elevated. Platelet count was 2.5 lakhs. Total cortisol, because he doesn't have any previous comorbidities, but he was found to be dyslipidemic after the initial investigation, and the CRP was found to be 20. The eosinophil was also within normal limits. The initial echo showed no RWMA, good LV function, no diastolic dysfunction, trivial MA, no other abnormality. Chest X-ray taken was also normal, which was taken on the next day. And so we just want to know the pathophysiology of this thing. So we decided to do an OCT run of LAD and RCA. Due to logistic reasons, we couldn't do it on the same day. We performed it on 7th April. And it's the OCT run of LAD, which showed an intimal tear and a plaque erosion in the proximal LAD. Proximal to it have a red thrombus. This was OCT run of LAD. We can see the intimal tear, and proximal to that we had a red thrombus. And we also did the OCT run of RCA, showed a intimal tear with a plaque erosion. Intimal tear with a plaque erosion. LAD was showing intimal tear with plaque erosion and red thrombus, RCA intimal tear with white thrombus. With the background history of an allergic reaction to beef, followed by development of ACS, OCT assisted angiography, we have proven that thrombus with plaque erosion and intimal tear as a possibility of Coyne syndrome cannot be ruled out. Allergic. An allergic reaction which can present as ACS.
But that is usually described in bee bites.
Also
Bee
the-
stings. Bee sting.
Bee sting, yes, sir. Usually it can allergy to other drugs.
But no, but then mostly, sir, it
No.
happens secondary to some injection like adrenaline, which is also given. So this is vessels go into spasm as well.
Yeah.
Yes, sir. Yes, sir. COVID. Yes, sir.
I do not know whether Coney syndrome is something happens in any allergy. I was under the impression that it is mostly related to a multiple bee stings. Bee or in that group of in that particular group. So it is mostly related to bee stings that is this particular term is used. I do not know whether it can be extrapolated to beef also.
Drug allergy, even drug allergy, food allergy can be cause for this.
But then you are saying that the problem has happened because of the drugs that has been used to treat allergy.
Local
But
Avilan
here-
hydrocodone.
Hmm.
Stress situation, there will be hypercoagulable state in this situation. There will be fluctuations in the sympathetic parasympathetic system. So there will be an endothelial tear plus the hypercoagulable situation which happens in this, which produces. So Cooney syndrome was first described with bee bite, but the mechanism is the same. So you can put it as Cooney's like syndrome.
No, we do not know, Sudhamar, whether the bite of the bee also in large quantity, a large number of bees bite, whether there is a toxin which can
That
also cause all
can.
these problems.
So many things can produce.
So
Because it is
I'm
not-
saying that Coney syndrome cannot be used for beef eating.
Okay, but the mechanism is almost the same because it is not primarily the lipid rich or soft, whatever we talk about, acute plaque erosion. It is not that. There is an acute hemodynamic plus hypercoagulable state.
Doctor, why is that in LED you had a red thrombus and in the RC you had a white thrombus? Any explanation?
Actually, cancer concept, we could do the other things.
Could this be one has a plaque rupture and there is not only plaque erosion? Okay.
Was there a history of fever?
No, sir,
weeks back
nothing was.
related to
Nothing.
I think these are some
Because-
situations like a stress cardiomyopathy. Sometimes you have something like that where you have a fluctuations of the, it's actually a neurohormonal reaction and the shifting hemodynamics is produce a tear.
What was the echocardiogram? Was it showing any particular pattern which may make you think that it may be stress cardiomyopathy?
It was
Nothing.
nothing was there.
Normal.
Normal. Oh.
At the time of admission, at the time of discharge also. there
Okay.
was-
Anyway, it's an interesting presentation. I think we'll now look forward to people who are taking beef and coming with Coney syndrome. Thank you.
Thank you, sir. I think so. We come to the fag end of the day. I mean, a special word of appreciation for Professor Manjura and Professor Sudhir sir. I think they are great teachers and stayed all throughout. And Dr. Gopakumar for having patiently waited all this time, all this long. And thank you. Let me now call Dr. Jitu to finally, I think it's supposed to be officially a validatory function. Let me put on record the excellent effort taken by Dr. Jitu and the team and the whole I mean, wanted to thank everyone. Very meticulously planned and done. I mean, really appreciate and a wonderful hospitality.
Thanks a lot. It was never possible without the help of Jagopal sir. Also was very nice and he agreed to perfectly.
Modern thing I feel is that he started planning almost 3 months ago. How to approach how to collect money, how to approach how to ask people to present cases, all those things. So I think a lengthy planning, meticulous planning was the most important.
Mangam, special word of thanks to you and also to all the audiovisual team, Moses and group. Thank you.